Thank you, dignitaries, for gracing the ceremony. May I request you to kindly take your seats. I now formally welcome everyone gathered here. It is my privilege to invite Dr. Rubina Shahnawaz, Clinical Coordinator of the workshop, to deliver the welcome address. Ma'am, I request you to kindly address the gathering.
Thank you, Dr. Delsita. She is our anesthetist and has graciously accepted to MC this event. Thank you. And sir, we need a few words from you now. Yeah. Welcome, everyone. Thank you for coming on time. That's a rarity in Bangalore. So for honoring your time, which you have given for us, we are planning to start at Indian Standard Time, half an hour stretched. So thank you very much for being here. This is, as you know, 3,000 robotic cases commemoration, and we are here to share with you what we have, the obstacles we have faced, the challenges we have faced, and all of that. He'll come later. Okay, done. All right, so with this in mind, we have curated, it's very short to do entire Gynae in like 4.5 hours, but the commonest procedures, what the challenges are, and we have tried to make it interesting. It's a 20-minute of presentation, 10-minute questions, always can be extended as per how you want. Most important, we have the intuitive simulation center down outside. It's a van outside the hotel, so you'll have to get out of the building and go. So in between, I hope you don't get bored, but if you need movement, circulation, please do go. Hands-on. Robin is right here, and we have all our people around here who will take you there, do the simulation and come back. And I'm really grateful to Dr. Mahesh Koregal, sir, for accepting our invitation and being here. Thank you, sir. Thank you so much. Yeah, I'll ask Delsita to take the events forward.
Thank you, ma'am, for your warm welcome. I now request our honorable chief guest, Dr. Mahesh Koregal, to share a few words with the audience. So I request you to kindly address the gathering.
Good morning, everyone. And at the outset, I thank organizers for having me here as the president of Bangalore Robotic Society. And the robotic whole workshop or the conference is actually really exciting. And today, the era has progressed from somewhere where we were doing vertical incision to financial incision, and then slowly getting into laparotomy, where the cycle pumps were used in the government hospitals to inflate abdomen and do the tubal sterilization, to today's advanced surgeries from basic laparoscopy to 3D laparoscopy, now graduating into robotic surgery is something heartening to see. The more the advancement are there, the more the affordability also is increasing now than before, because a lot of things are out of patent, and a lot of people are able to be trained, able to have more machines. And Fortis is one of the leading robotic surgery units in so many years, I know. And wonderful work is being done by the team, and especially in the field of renal transplants. I could read that so much of advancement has done across the world. So reaching them is something that is a feat by itself. So I congratulate the team. And always there has been a very good, what I should say, development in this field. There are a lot of lab surgeons and greater surgeons who are graduating themselves into laparoscopy. So many of you I know are here. Nisha Buchde is here, and Rubina madam is here, Manisha madam is here, and Parimala. All of you I know have been doing a great work from so many years. So going forward, this is only becoming more and more advanced, and much more. Maybe when you are having next CME with you, we'll have much more advanced procedures or equipments which will lead to a lesser hospital stay, lesser incision, lesser blood loss, lesser infection, and the patient comfort is more. So this is what we always look at when you're treating any patients in any specialty. Robotic surgery has made this dream possible by this. So this is very heartening to see a whole conference is being organized on this. I think more and more people will come forward and get trained in this, and more accessibility will happen, because now it is limited to few bigger cities. I hope this goes to tier 2, tier 3 cities also, and more people will be able to get into the robotic training and then offer it to the patients at a competitive rates as well as the competitive expertise. With this, I finish my 2 sentences. Thank you again for inviting me here. Thank you.
Thank you, sir, for your warm and inspiring words. I now request Dr. Rubina, Dr. Manisha, and Dr. Parimala to felicitate our chief guest. With the inaugural ceremony coming to a close, we now move on to the scientific proceedings of SURGX. With this, I would like to invite our first speaker of the day, Dr. Prakriti. She is a consultant in advanced gynecology and urogynecology at Fortis Healthcare, Bengaluru. She is a skilled laparoscopic and robotic surgeon with special expertise in minimally invasive gynecological surgeries and pelvic reconstructive procedures. She is among the youngest robotic console certified surgeons in India on Da Vinci surgical system. Her clinical interests include robotic and laparoscopic surgeries for benign and malignant gynecological conditions, endometriosis management, and ERAS protocol. Join me in extending a warm welcome to Dr. Prakriti.
A warm welcome and a happy good morning to all of you gathered here. Thank you, Dr. Delsita, for that kind introduction. So, as we all gather here to celebrate the humongous achievement of 3,000 surgeries in robotic Da Vinci system, we thought that we should be sharing our knowledge, the hows and whats of robot. So to know the hows and whats of robot, what are the technicalities that is involved in it, how to perform, what are the most common troubleshooting aspects that we can look into. So that is what will be covered in this talk. So I request all of you to just pay a little attention to this so that this will give a very strong foundation into what we're going to say further, the robotic setup playbook. So this is the most common question our patients and your patients will be asking you. Doctor, are you going to perform the surgery or are you going to feed the steps into the robot and that is going to perform? So we all need to assure them that it is us who is controlling the robot and it's a master and a slave concept. The eyes, the hands and the legs are of the robot, but the brain and the technique is of the surgeon. It always remains with the surgeon. So in case your patients wonder why the doctor plays video games all day, he's actually controlling the robot. So why the robot in the first place? Historically speaking, robotic surgeries were invented to make sure that tele-surgery is possible. So there were places, especially in the war zones, where the doctors and expert care could not be reached on time to save the lives of the soldiers. So this is when the surgical team thought that we need a system where the doctor could, if he couldn't reach the place on time, he could sit somewhere and operate at least the life-saving procedures. That's how it was started to be used in war zones. So the first recorded use of robot was in the use of a brain biopsy, which was by CMR Surgicals, where they used the precision and the tremor-free movement of the robot to take the brain biopsy, which is of utmost importance. So currently the robotic systems that we have give us an edge over all the surgical modalities that we have for the following reasons. The camera is a high-end binocular 3D vision, high definition vision. It gives a magnified view of 10x. So it feels as if we are sitting inside the abdomen and seeing each and every capillary, each and every fiber, nerve fiber or a vessel. So it has also an excellent depth perception, albeit it comes after certain experience only then. Because there is no tactile feedback, the depth perception also could be a little hampered. So the endorest or wristed instrument gives us a 7 degree of movement. Sometimes it actually mimics the wrist movements, but it actually is more than what the wrist could do. It can reach places where our wrist, even in an open surgery, couldn't go. So that is one huge advantage. And motion scaling converts large hand movements into precise micro movements. All of us are laparoscopic surgeons. So it gives something known as counterintuitive movements. If we want to go up, the hand should move down. If we have to go left, the hand should go right. So this needs a little training in the hand-eye coordination. But in the robot, it is an intuitive movement where if the hand goes to the right, the wristed instrument also goes to the right. You open the jaws, you cut, everything can be done boldly and which is tremor-free, and even small movements are converted into the appropriate scaled movement in the patient's body. Stable camera platform, and it is controlled by the surgeon. So they need not keep instructing the assistant if they're not in par with the surgical steps. The surgeon himself can control the camera and go where he wants to go and see whatever area of interest that he wants to see. Obviously, because with the console is where the surgeon sits, there is no physical and mental strain on the surgeon. So the prolonged procedures will be done at ease. Multiple robotic arms are available, not only two, so that we have good vision of the area of interest with retraction arm also. The energy devices like bipolar, monopolar are integrated into the system, and it is very easily controllable. This will give an advanced vessel sealing option. So the additional features of this is the Firefly technology, where we use ICG dye and it can be lighted up in case of lymph nodes or ureter. It can be lighted up and the organ of interest can be seen with precision. Assessment of tissue perfusion, lymphatic mapping is all where we use it. Another most important thing here is digital integration. So one thing what I was telling, telesurgery, you sit somewhere and you operate on a patient elsewhere. This was the primary reason, which will be a reality in near future. And along with that, dual console capability. If there are two surgeon consoles, then if this main surgeon is operating and anywhere the mentor needs to take over, the mentor can take over sitting at a different console. So there is very, very, very low margin of error in this concept. So video recording and a high definition image integration makes it even more easy for us to share the videos with audience who need to know more about it. These are all the advantages, technical advantages. But how does the patient know why should he get a robotic surgery? So there are smaller incision, reduced blood loss because it's a precise dissection, less post-operative pain, lower wound complication rates, shorter hospital stay, faster recovery and earlier return to normal activity, improved cosmetic outcomes. So physically, mentally, financially, everywhere it is actually helping the patient. Especially for complex gynecological surgeries, we doctors would prefer to do robotics because it is excellent for obesity and deep pelvis organ dissection, facilitates nerve sparing dissection, superior suturing. Suturing is the most difficult thing in laparoscopy. This is the first thing we learn in robotics, especially for myomectomy, sacrocolpopexy, where we need to go precisely. Helpful in advanced endometriosis, especially in oncological procedures also. So why are we stressing so much upon the setup? That's because 70% of the avoidable intraoperative issues originate during the setup itself. Rest 30% is more of technical, which happens after the surgery starts. So we need to be very thorough before the surgery itself. So a proper setup will reduce all these preoperative issues which come. It improves ergonomics, prevents arm collisions, enhances patient safety, and improves the operative efficacy. So starting off, know your robot. So the current system that we are using is from the Intuitive Surgical, the Da Vinci system. We have used both X, SI, and we have had the opportunity to use the SI also. The first system that was introduced in this regard on a large scale was the SI system, then came the X and the XI. XI is the current advanced, and the next which is upcoming is the DV5. So basically, the robot has three major components which need to communicate with each other for a seamless surgery. That is the patient cart, the surgeon console, and the vision cart. So each of them perform the specific function so that the surgery is done seamlessly. Let's go into deeper aspects of everything. Surgeon console, which is the most important thing for a surgeon. This is the place where the surgeon sits, operates, sees the organ, and operates all the energy devices as well as the camera. So if you see, it has three major parts. The topmost portion which you can see is the stereo viewer, where the doctor's head and eyes are inside. And in the middle portion, if you see, it is a handrest, and inside we have clutch, something like scissors what we hold in our open surgery, which is used to control the instruments inside. And the lower foot pedals are the foot pedals which have the energy control and the camera control in them. So the head portion has many features based on the surgeon's comfort and height and the seat height. He can tilt it or make it up and down. Same thing happens even with the middle armrest and even the footrest. It can move front and back. So the ergonomics can be adjusted according to the surgeon, and it can be saved in the system. So whenever in next surgery the surgeon wants the same setup to be done, he need not waste time setting up each and every component. If he just presses the apply saved ergonomics, the ergonomics are set according to that surgeon. So every surgeon can have his own profile into the surgeon console. So there's a video explaining, showing all this as well. So this is the patient cart. This is the cart. The surgeon console sits in the unsterile or the non-sterile area. So this is the patient cart which is going to interact with the patient, and it will be sterile. So the center beam which hosts the arm is called the column, which is also draped, and all the arms which you see are attached to one single boom. This is the feature in an XI robot. In an X robot, all the arms are attached to the column. So the boom is rotatable. The arms are movable at two different joints, and the arms hold the instruments. So the arms contain the connection between the instrument and the port, which will communicate the surgeon's movement and the surgeon's decision inside the patient's body. So how we go about doing all this is again explained in a video. So now this is one important aspect even for a robotic part. This is called as a vision cart. So the first one is a monitor, and the rest of the portions what you see hosts the endoscope, the light and the camera controls, and the energy device controls. So the energy device controls are available to the surgeon as well on the surgeon console, and the camera control also. But just in case if he wants the assistants to do the technical assistance, then even they can do from a vision cart. So this also sits at the unsterile area. So few features of this vision cart is it is a touchscreen monitor. It gives all the information about the instruments being used and the vision how it is for the surgeon inside as well. And because the robotic endoscope camera is a binocular vision, the surgeon gets a binocular vision which is 3D. But what the vision cart or the other screen show is a 2D image. So either from the left eye or from the right eye. So sometimes if due to surgical splash out or blood or anything blocks one side, the technical assistant outside can touch the vision cart option and change the vision so that the vision becomes clear for the people who are observing the surgery. So it provides a high quality view of surgical image and allows non-sterile OR staff to adjust to vision setting and troubleshoot faults. Another very important aspect of this touchscreen monitor is whenever the surgeon is performing the surgery, the senior surgeon can mark on the touchscreen and show exactly where he wants the surgeon to go and dissect, or which particular part he needs to observe. So if the surgeon marks on the screen, it comes with a green marker, and it is same relayed into the surgeon also in the console, real time. So if ma'am wants me not to go to a particular structure, she'll tell don't go there. So I can see the cross mark which is there. So this is one important aspect when it comes to mentoring. And because the energy devices are integrated into it, we need not move around the energy devices as we do in a lab to set up the tower. It is all in one setup, and this will reduce the time taken for the initial setup significantly. So the main thing which we use is the instruments. We have various instruments which are available. Most commonly we use the fenestrated bipolar, which is the bipolar energy device, a monopolar scissors, and progress forceps for the retraction aspect, and monopolar cutting energy generator, and obviously the endoscope cameras. The endoscope, we use both 0° and 30° based on our usage, but most of the time it is a 30° binocular vision endoscope camera. So the accessory things that we use to make a robotic surgery more easy, because when the robotic system is docked onto the patient, we can't move or we can't do much. So we have certain accessory devices which we use to make our life easier without much hassle and taking time. One of them is the air seal. Air seal is a system which will maintain the pneumoperitoneum inside the patient's body. So whenever there is suction coming in, or whenever due to any reason there is loss of gas, or even if the insufflator is giving too much pressure, we need not let out. The air seal itself detects the pressure which is set, and it will maintain the pressure no matter if there is excess gas or less gas. So if it is less gas, it will push in the gas. If it is excess, it will let out the gas on its own. We need not do it. So it's a 12 mm port with a 3 lumen. So the 3 lumen function is, one thing, it helps in smoke evacuation. Second thing, it senses the insufflation pressure and maintains it. And it creates a stable pneumoperitoneum. And because it's a 12 mm, it's easy to take out the minor tissues like tubes and certain tissues for biopsy easily from this port itself. We need not create one more port just for this sake. So it is connected to a system which will detect all this, which will help us to operate at much lower pneumoperitoneum, like 10 or 12 as well, even in an obese patient. So this mostly sees use in cases of obese patients, extremely obese patients, and in surgeries like sacrocolpopexy, and where we are expecting, as soon as we open the wall, there is sudden collapse of gas. So that doesn't happen if air seal is present. So this is not a dockable instrument. This is usually what the assistant uses to push the laparoscopic instruments inside. So this is one more accessory that we use. This is called as a yellowfin Allen stirrups. So we make the patient lie down, and we keep the patient's leg into the yellowfin stirrups. If you can observe in the video, it is well padded. So the pressure points are not under a lot of pressure, because in prolonged surgeries, if we put that, there may be pressure source on the patient, there may be pain. So that and all is avoided by this. And because it has multiple articulate joints, once the patient is put in position into the lithotomy, it is draped, and the surgeons or the assistants can decide how much of a hyperabduction is required, how much of low lithotomy or a high lithotomy is required, and it is all adjustable by the assistant or the surgeon in the sterile glove itself, because it is all draped and it is easily maneuverable with that handle which is given there. So this also reduces the robotic surgery time taken to do a robotic surgery pre-operatively very significantly. So how is the usual robotic OT setup? So robotic surgery is always a team effort. So it's not a single man's effort, it's always a team effort. So what are the team members and what are their responsibilities? So if you see the image, obviously the anesthetist sits at the head end, who needs to control the patient's entire physiology during the surgery. And on the patient's left side, if you see, it is the patient cart which is coming into the sterile area. So based on the area of interest and the port placement, we can keep the robot on either side or even at the vaginal end. So in the XI system, side docking is possible. In X system, extreme side docking is not possible. We'll have to keep it more towards the leg for pelvic surgeries. So the assistant is on the side where the assistant port is. So sometimes it is on the right, sometimes maybe it may be on the left based on the need. And the nurse is present at the side with all the instruments, and surgeon is at the console in the same room. So surgeon will be responsible for planning the surgery and console control. The assistant will be responsible for the port placement, the suction, and if there is any stapling involved, and any other laparoscopic and vaginal assistance. The scrub nurse will be responsible for handling the instruments, and if there is any sterility issues that comes in. The circulating nurse should have to be trained in robot positioning as per the surgeon's requirement. The anesthesia team obviously will look into the patient positioning, how is the cardiovascular system going to take up the positioning, and all of those things. So this is how usually our OT setup is. So this is a Trendelenburg position that we have given with the X-robot docked at the vaginal end. So it is a modified lithotomy at the low lithotomy position. Here we have to ensure that the patient is well supported in all the pressure points. So the shoulder pads, shoulder support, the gel pad, all will help in pressure point protection. Arms must be tucked, and all the lines must be made sure that they are not getting compressed. the secure IV and arterial lines, Trendelenburg to move away the bowel and pelvis as per the patient's CV system allows. Certain areas of access, we can do the tilting and all of those things and see into it. So routine protocol as per any surgery is followed even in the robotic surgery. So this is the port placement that we do. Varese entry is preferred, not an open, because in robotic port placement, it is very important that we make a proper incision to host the port. If it is bigger, the port will be loose and the docking may fail. If it is too tight, obviously the port placement may be difficult. So all the standard ports are 8 mm. Interport distance is 8 to 10 centimeters so that the arms don't clash. Better to keep it at 8 centimeter. It could be at the same line or inverted triangle. For the pelvic surgery, most of the time it is a standard port placement, as you can see in the picture. So the cannula is the one which we use for robotics is this. So it has a knob which will go and dock into the robot. And if you see, the most important point is the 3 black lines that you can see, 2 thin lines on either side and 1 thick black line. We have to make sure that the thick black line sits at the peritoneal level so that there is not much of a movement at the skin. So that is the whole point when we say robotic surgery gives less pain. Like laparoscopic surgery, there is no shearing movement at the level of the skin. To ensure this happens in the robotic surgery, we need to keep this thick black line at the skin level. And we have to put the ports always in an inflated abdomen, not on a deflated abdomen. Please don't mark and put the port. So docking, I think better to show in a video itself. So this is a small video which is showing how usually we do a robotic setup. So we have the surgeon console placed here on the left, which you can see. This is the vision cart which is at the leg end of the patient, and that is the patient cart which is coming up. This is the XI system which we just saw, and we saw the yellowfin stirrups as well. So all these systems are connected by multiple cables which run on the floor. So that has to be seamless so that the surgeon's movement are immediately transmitted into the robot. So this is the place where the surgeon's head sit. So the area pointed is the infrared. So when the surgeon's head is inside, the infrared sensors will sense that the head is inside, and only then the the instruments move. Once the surgeon takes off his head, the instruments freeze. They don't move even if we move the arms down. So this is very important and a safety feature that is provided by the company. After the surgeon sits, he will adjust the ergonomics. This is the clutch, the port controlling hands. So it opens and closes, and it has a clutch so that you can adjust your hands without moving the instruments at the console. So if you see that small touch screen there, that is the place where the surgeon controls his ergonomics, the energy controls, the camera controls and all. Even the firefly system can be switched on and off from there. So the energy controls are at the foot end on the right side, both the bipolar and the monopolar instrument, and it is interchangeable. So if you want the bipolar on the left, it can be put. If you want the bipolar on the right, it can be put. However you want, it can be done. So these are the instruments which are being shown. So the instruments are usually 49 to 51 centimeter long. So even if we go higher, we can easily reach the deeper parts of the pelvis. So that is why the planning portion is very much necessary. So the ports look something like this. If you see the protrusion which is there, that is what is going to go and sit into the robot. And these are the drapes which you see, the plastic which is going to be draped now. So this is how if you see the column, the center column, that also will be draped because it will go close to the patient and the sterile area. And these are the arms. So the internal one obviously is cleaned, but the external, over that we put the plastic drapes which is sterile. So this has magnetic attachments at the arms, and this attachment is important again because the electrical signals travels through this as well. So it has at the fag end, it has one magnetic attachment, and it has 3 attachments at the robotic arm end, which has to be ensured that it is tight, or else anywhere if it is loose, the instrument doesn't sit and instrument doesn't go inside at all. So this is the place where the robot arm is docked. So once the patient ports are placed and the robot is positioned, we put the port into the robotic arms. There's a hollow in the robot arm and a protrusion in the robot port. So this goes and sits, and this is called as docking. So this docking should be ensured so that the communication between the surgeon and the patient is seamless. So you can see the hand movements happening at the surgeon's end is being directly transmitted at the patient's end via the patient card. This is how usually the surgical robotic system setup is done. Thank you for your patient hearing. If anyone has any questions, we can take them. Thank you.
Thank you, Dr. Prakriti. That was a very interesting talk on robots. So just to wake you all up, I have a few questions. I wish all of you to participate. Which food item never spoils? Does anyone know the answer for it? Yes. Another question. What is the primary ingredient in marzipan? Marzipan. It's a sweet. Anyone? None of you all have had it? So it's almonds. So moving on to the next talk. It's my privilege to invite Dr. Rubina Shanawaz, Additional Director, Department of Urogynecology and Robotic Surgeries, a distinguished clinician and academician. She is a triple gold medalist, co-editor of a book on urogynecology, and first female gynecology proctor for Intuitive's robotic system in Karnataka. She was recognized among the top 5 robotic surgeons of South India by Time magazine in 2022 and is a recipient of Femina Achievers Award in 2026 for innovations, for excellence in gynecology and women's health innovation, a sought-after faculty at numerous national and international conferences. Please join me in welcoming Dr. Rubina.
Thank you, Dr. Delcita. So it's a privilege to have you all here for our CME. And it is, I mean, I got scared hearing Prakriti's presentation. It sounded like it's a huge device which requires lot of technicality and training. It sounds that because safety is paramount. But once the main advantage, because of which we all are able to operate, otherwise you know how seniority goes when you come to surgery. You know, the more experience you have, definitely. But here, robot kind of equalizes the balance. The entire team is able to operate with the same skill set. And it definitely shortens the learning curve a lot. So that way, I think it's a real game changer. So, ಅದು ಓಪನ್ ಮಾಡಿದಾಗ ಬರುತ್ತಾ? So my topic today, so this is about, so you saw how the technicality goes. Now this is what magic can you do using those techniques. So I chose that let's talk about robotic myomectomy and benign hysterectomy. I'm doing the myomectomy part first because that was what took me a long time to change to the robot. And yeah. So I mean, we started doing the robot for urogynecology, gynec onc, and we thought it's only for complex endometriosis. I wasn't convinced for myomectomy or for benign hysterectomy. I said, I'll do it easy with lap. I mean, what's the big advantage? Then when we tried the first few cases, and then when we saw the advantage, as I walk you through, you'll know what the advantages are. That's when I knew it has a role to play even with benign pathology. So here, yeah, so patient selection, always, I mean, I'm not going into the details of the who, what, why. We are here to talk about the technology and the technique. But when you start off like how we say, you know, when you start off doing a TLH, go for like a failed AUB, don't go for big uteruses in the beginning. Similarly, when there is a uterine preservation which the patient wants, when you think there's prior abdominal surgery, adhesions are going to be there. Obesity, which we are facing a lot of, it really makes the job easy when we use a robot on them. And when suturing, it's such a pleasure to suture with the robot. And you know, wherever you want, you can put the incision, you'll be able to suture. So that's the advantages. Now, limitations. As you go, you can take up. You know, if it is a big uterus, it's a huge fibroid. Still, once you've done a couple of cases, you can go. But initial couple, try and stick to the basics so you can master your techniques. And always, always, always pre-op workup for, we usually, I mean, if you have a good sonologist who you trust, 3D ultrasound or an MRI, you have to map your fibroids. Otherwise, why? You don't have tactile sensation in this. So you can't say, I'll go feel, poke and see if there's another fibroid. So better to map the fibroid, have your GPS ready, put it on the system when you're operating, and then go in. The DV5, I think, I don't know if they are coming up. The Intuitive is launching it this month in India. So that has all this integration where you can put your imaging onto your console, you can record, all that is possible with the DV5. But obviously comes with a cost. Yeah. So then this I'll just skip. Yeah, this is the paper with myomectomy, robotic versus lap versus open. Is there a role for open? Still, definitely, yes. Especially if there are too many fibroids, more than 20, because time under anesthesia is important. Just to prove a point, don't put the patient under anesthesia for 6 to 7 hours. So when there is a huge myoma burden, huge fibroids, so we have a case who we are operating on Monday. It is a very rare case of disseminated leiomyomatosis peritonei. She has a 33-week, everywhere there are fibroids. There are 12 to, hopefully the next conference I can show it to you. We are doing open. In the subacute plane where she had a lap earlier, it's sitting there. So it's a very interesting case. We are not doing any minimally invasive, just going open and doing that patient. So patient selection is very, very important. And where does the advantage come? It is with suturing, suturing, suturing. Second is blood loss, because you're able to see those small little bleeders. You'll think, oh my God, I hit a big vessel. It'll be nothing. So hardly anything. We usually, just because the anesthetist is scared, we reserve blood. But touch wood, hardly have we had to transfuse blood for our patients post-myomectomy robotically. And cost, yes, that's the whole limiting factor. Conversion, hardly, again. Because lap, lap, you can't bypass lap and move. That's only for onco where you can jump from open to robotic. Anything else, you have to know lap. Somewhere you're stuck, you need to know to complete it minimally invasive, how you promise the patient you'll complete it. So that's an important skill which cannot be bypassed. And the steps we'll run through as we go, the same steps. Port placement, very important, because it shouldn't clash. Like Prakriti was saying, that's where it plays a major role. Port placement, there should be like 8 centimeter distance. Initial cases, mark. Always mark. Don't be overconfident on an inflated abdomen. Because when you do it, when the patient, you have not started gas, the measurement will change. Docking, again, the technician will do it, but you should know if your technician knows to do it. Vasopressin, always again for blood loss. Then the incision, enucleation, multi-layer closure. Tissue extraction, again, is a whole different topic altogether. We'll try and cover a little here, because so many ways of tissue extraction are there. So I thought, let me start with this, a huge cervical fibroid. So this lady had completed family. You can see that fibroid sitting there, bigger than the uterus. But she was 33. We didn't have the heart, and she kept, delaying the surgery because she wanted, everybody told her hysterectomy. So we told her, of course, take consent for both and go in. Here you can see the bladder is pulled up. Cervical fibroid, always take away what you know you'll injure, ureter. And this makes it easier. Yes, you can insert ICG prior. You have the option, but you'll beautifully see the peristalsis when in a robot. So what we are doing now here is identifying the ureter all the way down up to the cervix. What you see on the side, it'll move on the side like a serpent. So, and then you move it on to the side, either side, keep it away. Go in front, keep the bladder away. Then you go to your fibroid. Just because you see one thing there, don't jump into it. And then here, what we are doing again is going and identifying the external iliac vessels. We are trying to identify the uterine. And we also did coagulate the uterine, internal iliac, going on to the uterine. I'll just fast forward it a little till we see. Yeah, there. We are ligating the uterine artery again. So it is so that the blood loss is bare minimum and we are able to save. So all this going into this deep space, and I have the camera in my control. So I don't have to keep telling my assistant if the assistant is not there that day for some other reason. I can manage with one OT tech. I don't need the entire team to be present. So here you can see that, and the arms, you can see how they move. It's not a straight stick instrument. So the difference again here, what I realized as we did more cases, it's straight stick. To reach that, you'll keep moving in the abdominal wall, and that's where the post-op pain comes. I clearly know which is the lap port when the patient comes for follow-up, and she'll say that port on the left is paining, because that's where the lap port would have been. Robot, not one, they'll complain of the port side pain. So that shearing effect, this is only the tip which moves, and it moves, however, I'll show you in the later videos, 360-degree movement really helps. So now that both are out, this is the left ureterolysis. We have moved away what we want to save. Now we are going in for the fibroid. So that is the vasopressin coming out. It's not urine. Okay, so so that's the fibroid which we are going up to. It was largely, I mean, as you know, they grow out. That's why it's so visible, the subserous fibroid. The challenge comes when you go deeper. Again, another advantage with the robot is there's something called port hopping. If I'm not able to see it from here, I'll take my camera out, I'll put it on the side. So I'll be able to go in from the right side and see where it comes out of, and I can clearly save the uterus so that I have something to suture. If there's nothing left, what will you suture? So all those advantages. So here, now we have reached the base, and again the technique changes. So in lap and in open, we are used to traction. Yes, traction, counter traction is a must. Rollover technique. In fibroid, so we kind of roll. It's like a football you play, like roll, and go down. So that's the major this thing with the robotic myomectomy. So here we go down the base. What I wanted to show you, yeah, the posterior bulge is gone. Yes, there you see the sound is being put from the vaginal assistant. You can see it's come from the right lateral wall of the cervix. Now imagine trying to suture this laparoscopically. The kind of circus you'll have to do to get the suturing done. So the dilator is in place. I know where I should suture. So that first I need to get the endometrial layer together. Then we go layer by layer and suture it. And this patient, she was operated in Jan this year. We have done a scan. I don't have the scan image. Beautiful triple layer endometrium, menstruating normally with no issues whatsoever. There, this suturing is something which is a real pleasure to do with robot. So this is, I'm not going into the details of the, what suture material, all of it. Cut off the excess serosa, and at the end result, yes, so here you go. The end result, we have a beautiful reformed uterus. We didn't, in some cases, we usually give Lupride just to, keep them hormone suppressed till the myoma kind of regenerates, but here we didn't have to do that also. So there you go. So the uterus again reconstructed, and we had left in a Foley's for 3 days and then taken it out so that there is no intrauterine adhesions as well. The same thing, we had one which was on the left side. Again, one was on the right side. This was a left lateral cervical wall fibroid. I'll just run through. Again here, the ureter, everything, the steps remain the same. So what I want you to remember is, just because we have done 1, 2 or too many, basics should never change. Always go through the initial steps, because we have burnt our hands. We tried to do that, we ended up with fistula. So don't. Always protect the ureter and the bladder, and then go for the fibroid. So here, the same thing. So I'll just run it. So I'm able to show you all the videos I have. Again here, it was more of, a figure 4 than a figure 5, 6. So that created a challenge as we go deeper in. And again, we weren't sure if we would have been able to preserve the uterus. Here you go. So as we go in, then we kind of use, and usually myoma screw we only use if it is on the fundus or higher up. When we go deeper down, it's usually the tooth. You do have a robotic tenaculum. I'll show you in one, but again, cost. Each instrument costs. So when we tell this budget to our patient, we have to stick to the budget. So that's why you see a lot more lap instruments. In the foreign faculty, when they present, they'll use whatever instrument they want. We don't have the liberty. So yeah, that luxury we don't have, yes. So this is, yeah. This is not the tremors. This is the recording system, which gave heart that day. It was recorded at 30 FPS when it was supposed to be recording at 90 FPS. So that, yes, it's not, this is being tremored. Even if you have so much tremors, it is beautiful. So I know I can still operate at 70 when I don't know what tremors I'll have. So yeah, this is what it is. So there again, you can see that that's where it is. So that deep, that angle to visualize, to suture, And all this is made possible because of this technology. Again, this is what is being done. How many minutes do I have? 7. Okay, all right. So then this is multiple myomas. So here, like I said, we always map, do the aditiolysis, and yeah, so the aditiolysis, the anterior band, you know, it's there in most of the patients who have had more than 2-3 abdominal surgeries. Again, vasopressin. I'll move on to how suturing I've already shown you. Yes, this step. Initially, I used to cut a little and think I've already reached. But remember, the magnification causes the depth to appear, like objects appear closer than they appear. So this is, they appear farther than they actually are. So you have to go to that depth, and over time, you'll get to realize. So again, here, Pandora's box, we go on opening all the fibroids. And then the suturing, I'm just rushing a little bit because of lack of time. Yeah, so what I wanted to show you is wherever the fibroid may be, we are able to suture, and that you see is the endobulging. So when we have not damaged it, or even if it's superficial, we don't have to suture it back. We just push it back in and go ahead with the rest of the suturing. And this, anyone who has, you know, even 5 to 6 cases is more than enough to master robotic suturing. It's that easy as open surgery. And what I wanted to show you is the next one. Yeah, so this was a patient who was very particular. I think Shubha is not here. She was an anesthetist. Patient with myasthenia gravis, with endometriosis, with a 45-year-old, insistent on retaining uterus and multiple fibroids. She had hysteroscopic thickening. I said, let's just know. So first, and she wanted to know what her biopsy was. I say, let me do a DNC frozen. So we had to take her 3 times. She was also very claustrophobic. So for MRI, one anesthesia, then for hysteroscopy, one anesthesia. She wanted to know what the biopsy was, so she'll be clear if she can save her uterus. And then the last was this, the robotic myomectomy was done. And now when she came for follow-up, I asked, I hope you're looking to conceive. She's like, no, I'm not in that relationship anymore. I'm like, I have your uterus. So please use that uterus which you have saved. Here, what I wanted to highlight was this technique of threading. So this, I think even in lab we do, where this is the biggest headache after all the myomectomy when you sit and search for the fibroids. So this, from the beginning, we all keep count. The assistant keeps count. On the board, there's a count. And here we have a count. So it's the pearl necklace pattern, which we keep threading as and when we take out. So then this we take, we kind of make it into a necklace proper, put it into the bag, and then it's easy to take out, rather than sit and last you sit and search when you're mentally exhausted. So this is what it is. And then this, she also had all these fibroids. So what I wanted to highlight, yeah. So after we finished with the subserous ones, we went in for the intramural ones, the cervical one. So it was like a whole, but she went home the next day. She didn't know. We are the ones who had to stagger. So no blood transfusion, no prolonged hospital stay. She was able to go home, and she was not from here. So she was able to go back to her native in 5 days. So all this, I'll just, yeah. So here, this is the instrument I want to see on the left, robotic tenaculum. Very nice instrument, but you can't see. Sometimes I also use the bipolar to suture, just to cut costs for the patient when it's only wall suturing. But this I can't use for anything else. It's so, like, you know, dangerous to see under that magnification. It can only be used for this purpose. But if the patient is affordable, please go ahead and use this tenaculum. It will make your job much easier, and you can use this for presentations like what I have. So yeah, so this is with the multiple myomas. And then this is another thing I wanted to highlight. This we borrowed from urology. It's called a BK ultrasound probe. It's a drop-down probe. This is again the recording error. It's not staccato. So here, what we were trying to do is map to see where, if any, further fibroids. It's a drop-down ultrasound probe. We put it in. You can see, you can switch on the monitor. This is my console as I'm operating. And I can see where the fibroids are. What we were trying to do here is, for this patient, we were also trying to do a simultaneous ablation, microwave ablation. We have started doing that for adenomyosis. So we can see the depth to which we go, the effect we wanted to see, that whitening effect which was happening. So all that we were able to use this probe. Always we use an adhesion barrier before we come out. This is again a huge myoma. Now I think I'll move on to the tissue extraction techniques. Yeah, this all of you know. In-bag contained morcellation, always, always, always contained morcellation. Please don't take the risk. Of 200, the one who comes up with his DPL, that's not worth it. So this is something which we have put in the endo bag. We go ahead, time consuming. You know, the anesthetist will cry. They'll say, okay, you guys have started your morcellation, this OT is blocked. So that's where we decided to go ahead and try with this excite technique. Now we don't do morcellation, power morcellation anymore. Beautiful at the umbilical level, 3 centimeter incision. It's an applied medical device. You put in a wound protector. Then whatever bag, you use your easy catch bag, you use a Euro bag based on the size of the specimen, put it in. Cold knife morcellation. 1, you're not doing power. 2nd, contain. Again, 0 pain. And usually you'll know that port side where you put in the power morcellator, they'll keep coming back with pain. They'll forget everything else. Here at the umbilicus, no pain. Next day, they are able to go home beautifully. So this and time, within half an hour, even like a huge uterus, like, you know, we have done within half an hour around 24-week size also. So this really shortens the time. And again, no need of assistance. They should not be helping you retract, because if they take it to see that side, you'll lose vision. So it's just the surgeon who goes on, and no surgeon fatigue again. So this is what world over is used for huge uteruses. When they do pelvic floor reconstruction in other countries, they don't take out the complete total hysterectomy. They do supracervical. They put it in this and they take out routinely, and it helps a lot. And this is the evidence. Again, I'll skip. I think I'm running short of time, right? 45 minutes? Seconds, okay. Okay, so going on to benign hysterectomy. Benign hysterectomy, again, indications for benign disease, all of you know. Surgical technique remains the same. The pain-free period. So even today for the press conference, the patient who I operated, I never thought somebody will message me for anniversary of hysterectomy. She said, so it's her 3rd anniversary, it was this June. And she said, you gave me a new life, because she was able to operate. So she was pain, endo, adeno. We were trying to preserve. Finally, we decided to go ahead. And now the kind of pain-free life, and especially the patients who come back in a week and say, my community people are asking, why are you walking so fast downstairs? Because they are not able to feel the pain post-op. And when they have this, look at where we are, this anterior abdominal wall adhesions. You can see how my scissor is moving. So all this we won't be able to do with straight stick instruments. So I'm able to go right up to the anterior abdominal wall and this is the scissor. You can see like the 360-degree movement. That is possible. There is a mesh which was there. We didn't want to disturb the mesh, but we wanted the adhesions gone. So with this, we are able to beautifully dissect wherever we want to. 30 up, 30 down, everything in your control. And all these patients will have dense bowel adhesions. And this magnification matters, because little here, there, we can easily injure the bowels. Prakriti will show in the last. I do hope all of you are staying till the last, because we have had really interesting cases where we were thankful we went in with a robot. All those patients, the magnification really helped us to navigate no bowel injury and do justice to what we went in for. So these are all the anterior abdominal wall adhesions which have been released. And also, these kind of huge uteruses for which you are going to do a hysterectomy. How do I know when I have reached the cervix? How does my camera go over? In lap, if you had gone lower down, your camera won't go down and you'll stuck at that step. What do you do? Here, I'm easily able to bypass that step. I port hop. I go to my lateral ports. I don't stick in the center. And always remember, you're head on. You're not standing to the side of the patient. So all this mind orientation has to happen. You're head on. You're having 40x magnification. And you can change your camera. You don't have to stick. You don't have to change it to 5 mm. In lap, that's again one thing. Why do you want to do that? Your same camera, all 8 mm ports, go to the side. See here. I've gone to the side. I'm able to see the uterine beautifully, dissect it, no blood loss, put in the cuff, do the colpotomy, and then go ahead and take it down. And this is one more technique. So morcellation, as a team, we are little lazy. So we try to save time wherever. This is one more robotic instrument called the vessel sealer. Again, we tried, not too happy with it. So this is just seals the vessels, but it's, wasn't really, we preferred the bipolar. Probably it was just what we were used to. So then what we do here for huge uteruses, cut it vertically. like, we know it is benign, there's no tissue spillage, nothing. Cut it vertically, put it down, and just pull it down. So you're not sitting and struggling for piecemeal and coring and all that. So this, again, because you have the magnification, your assistants there push, can't do, undock, go there, finish it with this camera. You don't have to change to the lap camera. But because the intuitive person is here, I'll say that DV5 has the lap camera which has been integrated, and it can facilitate that also if you need it. So yeah, this is where we are done. Okay, so this is with benign. So the key takeaways is lap principles, tremor filtration beautifully works, 3D vision, and this wristed instruments for sure. And suturing, it becomes a pleasure. You'll fall in love with the art of surgery all over again when you sit on a robot console. For benign, it is the outcome which matters to the patient. So it is you who has to decide, I mean, with the patient, like always, individualized therapy. There is, in all studies, there is nothing showing that one is better than the other, except for the blood loss and the pain. But where it matters is the surgeon expertise and how they know to use your system. So know your systems, know for which patient what will work, appropriate selection, training, and the cost context. That's the primary for optimal use. Thank you so much from our entire team. And if there are any questions, we'll take it here. Yes, ma'am. Yes, ma'am, please.
Good morning, everyone. This is again an opportunity to thank Dr. Rubina, who is really a great person to operate on the robot, because she is my handheld mentor when I have started robotic, because I am basically a gynecologist turning to the robotic work also. And it was a great presentation. Congratulations. And I would like to, that's a great gesture. And I would like to know, as a still a learner in this one, what is that, like these people, most of them are youngsters and who are coming for their pregnancy, everything. What is that makes you to addition, prevention, or anything, if it is thought in that line? I would like to, fertility preservation, anything if you can answer in this time given. And the anesthesia part also we have to really thank, because all these cases require a lot of this hand down. That's another thing like we have to acknowledge, and really great talk.
Thank you, Paribala ma'am. Always our cheerleader, first cheerleader from the beginning. And always, so thank you for being here on time from across. Please, ma'am. So to answer that question, fertility preservation, again, great help here. I didn't put in what we have done for ovarian cyst also. Again, I was skeptical, I'd rather do lap. But we have seen studies where the amount, they've studied how much tissue cortex, its preservation is important for fertility preservation. So because of the magnification, it is shown that we are able to preserve more. And they have studied that and seen that with the robotic technology, the tissue cortex preservation is more than compared to lap. So if it is possible for the patient, we can go ahead and use the robotic technology for dermoid cyst, endometriosis for sure, that will help. So all those also it helps. And for fertility preservation, again, ma'am, the number of incisions. I think those are more techniques than anything else. Yes, ma'am. So for myomectomy, the watertight suturing which we are able to do, because healing, it greatly benefits with, and the amount of normal myometrium we are able to retain. So they are able to carry forward their pregnancies to term because of what advantage we offer them with this. So for fertility preservation, definitely a game changer. Yeah. Yes, ma'am. Yes, ma'am. Challenging, yes, ma'am. Ha, ma'am. Yeah.
So that is another
Yes.
option if
Yes,
people
ma'am.
don't want to create a pearl necklace. But I really like that, and I'm going to try that next time.
Thank you,
The
ma'am.
second thing is for intramural myomas. One of the things that I have found, because there is no tactile, I have used the transvaginal scanning at the same time
Yes.
to locate where the fibroid is,
Yes.
and then make an incision, So I've had to take the help of my assistant to do a
Yes.
TV scanning the
Yes.
same time.
Yes.
And then when I point my scissor on it,
You
and
can
they
see,
say, we can see your scissor.
Yes.
This is where you need to incise, because you have absolutely no clue where to go, and because it is so magnified.
Yes.
That is one technique I found very useful. I'm sure the next
So
system
really
of
useful.
Da
Thank
Vinci
you so
that
much.
comes,
Yes, ma'am.
will have the incorporated
Yes.
mapping in it. But this is one of the things that I have
Yeah,
found
thank
useful.
you so much, ma'am. Really helpful, because this BK ultrasound again one charge.
Thank you,
TBS
Manisha.
we are all used to, so it's yes, yeah, yes, yes. Thank you
It was
so
a,
much.
it was a great added valuable point. Really, thank you for that. And because this is a very important topic, so just this one to really feel the taste of jamun, we have to eat jamun. I am basically telling because even though luxurious everything this robotic surgery, but when you get into that and practically try to experience, the things are different. Leave apart all the luxury and all. I think all gynecologists or anybody who can really learn this technique is something like welcome, because I have started learning at a very late age. No age is bar. That's what I wanted to convey. Thank you.
Ma'am, I wanted to know the incision, ma'am, like the incision, the main incision, do we need to enlarge it for myomectomy patients near the tissue extraction?
So it depends on how you're extracting the tissue. If you're using the Excite technique, it has to be a 2.5 to 3 centimeter incision. Power for the power oscillator, it's 1.5 centimeter only. Yes, ma'am. 1.5. That's enough. Or colpotomy. You can pull it down through that. Infra, no, ma'am. We go usually little supra. Supra. Yeah, that is easier for us to operate. For the 3 centimeter. So we have to ensure, like how in an open we kind of ensure the sheath, everything is closed. So we have to ensure proper closures to reduce the chances of hernia. Yeah, but this has been, there's a really pioneer in robotic myomectomy called Dr. Arnold Advencula. He's in the US. He introduced this 12 years ago. And he's been doing just this 12 years ago. I mean, since 12 years. So we have enough studies to know if dehiscence or hernia and all of it. And it is, if the technique is done correctly, the chances of hernia are really less. Yeah, thank you. Yes, one more question.
Yeah, if you need any lab assistance and
Yes.
all, how will you coordinate with them? Like, how will the lab surgeon will be coordinating with you? And
You mean my assistant? It will be all doing it robotically only.
okay,
And we have two, three monitors across in the room.
okay.
So the one who's sitting by the, I think she showed that video initially. And we can, if you go down to the simulation center, you'll be able to see it. So the one sitting by the patient's bedside can also see what we are doing while we are inside the console. So what we are seeing here is transmitted across the room. And when I talk here, there's a speaker on either side. So even if I curse them, they hear it amplified.
Okay. And one more question to doctor. Sorry, one more question to her. So when the surgeon is, you told that once a surgeon puts his head into the, what is it called? I'm sorry.
Console.
Yeah, console, yeah. The infrared rays, and they detect the presence of the head, and then the, yeah. Yeah, that's right. And what is, I just wanted to know, what is the maybe long-term side effects of that for the surgeon? I don't know. Maybe a valid
Nothing. Yeah. Infrared is usually a safer option. It is used for therapeutic purpose also. So it's usually not any harmful.
as of now. Okay. It's unsterile one.
Yes, there is coffee and sandwiches arranged outside. start the session at 10 sharp. Please be here at 10 o'clock. Thank you.
You could get the coffees inside as well. If it-
छंद क्या?
Shall we start the next session? I hope all of you are energetic. ठीक है. I hope everyone is energized now after a coffee and a sandwich. Roughly for the interaction, one more question. What fruit has its seeds on the outside? What fruit has its seeds on the outside? Strawberry. What belongs to you but everyone else uses it more than you do? Correct. Forward, I am heavy. Backward, I am not. What am I? Forward, I am heavy. Backward, I'm not. What am I? Ton. Ton, ton. T-O-N, ton. Forward, it's heavy. It's a ton. Backward, it's not. Okay. Now it's my privilege to invite Dr. Manisha Rajpal Singh, Director of Reproductive Medicine, Minimal Access of Gynecology and Robotic Surgery at Creations, Fortis Hospital, Bengaluru, a globally trained specialist with over more than 34 years of experience in reproductive medicine and advanced gynecological surgeries. She is the founder of Creation Center, one of South India's leading center for IVF and robotic surgery. Having performed over multiple laparoscopic, hysteroscopic, and robotic procedures, Dr. Singh is internationally recognized for her expertise in endometriosis, fertility preservation, and minimally invasive surgeries. She is also an accomplished researcher with over 30 plus peer-reviewed publications. Please join me in extending a warm welcome to ma'am.
Rubina, ये presentation 1 second. So presentation. Cancel. अभी open करेगा. It has a mind of its own. हाँ, ठीक है. Hello, good morning. So I hope the paid puja is done and everybody is now feeling more happy, but please don't feel sleepy. At the very outset, I want to thank Dr. Anant Rao, Professor Mohan Keshav Murthy, Rubina ji, and all the organizers of SURGX 2026 for their very kind invitation to come here and talk about my area of interest, that is endometriosis. So as a resident doctor in KEM Hospital, the minute there used to be a chocolate cyst, there would be a hoo-ha. Everybody would go, oh, no, only the senior consultant boss has to operate on the chocolate cyst, and they would do a laparotomy and then bung the patient on danazol for 9 months. And that was the end of the story. And then you didn't hear anything about endometriosis. It was only when I went to the UK and I joined as a subspecialist. I got my first intro properly with endometriosis laparoscopically. And we established the first center of excellence for endometriosis in the northwest of UK in 2007. And then I tried to replicate that when I came to India. So today we are going to talk about, since this is a session on robotics, we're going to talk about the role of robotic-assisted surgery for endometriosis. So as we all know, endometriosis goes, so when the endometrium goes beyond the borders and starts proliferating outside the uterus, we have endometriosis, adenomyosis, and what have you. 1 in 10 women are affected by this disease. And I would assume there must be more than 5 million women today in 2026 who are known to suffer from endometriosis, and then there are those silent sufferers that never come forward and assume that period pains is totally normal. When you look at the disability-adjusted life years, and this is data from 2021, more than 2.05 million, it affects the quality of life, it affects the work hours, and what have you. So we all know that when we put a scope inside, you find superficial peritoneal disease. What we all love is the ovarian endometriomas. And then there is deep infiltrating endometriosis that can get a little bit tricky for everybody. But basically, when there is more than 5 millimeter infiltration of the endometriotic cells beneath the peritoneal surface, that is when it starts getting classified as deep infiltrating. Dysmenorrhea, dyspareunia, infertility are the common triad, but when you take a history, please also ask about the bladder and the bowel symptoms that patients experience, because this is very important. The first step in diagnosing endometriosis is a thorough history and a proper clinical examination, even before you start doing an ultrasound. And there may be a need to do a per-rectal examination in these patients as well, because there is bowel involvement in up to 1 in 3 cases, and the bladder ureters may be involved in up to 6% of the cases. So this is the classic presentation. So first you have, the cursor isn't moving. Anyway, so the first image is superficial peritoneal endometriosis. You see the blue, black, brown spots. You see neovascularization. There isn't a pointer. Okay. The next picture is that of ovarian endometriosis. The third is a bowel lesion, a small bowel lesion. The next one is obliteration of the rectovaginal septum. And then, of course, you have the ureteric involvement. So traditionally, we all learned about the American Fertility Society classification of stage 1 to 4, mild, minimal, mild, moderate, and severe. And then the Enzian classification came up that compartmentalized the endometriosis, especially in relation to the DIE. So you have the ABC, the rectovaginal septum, vagina, the uterosacral ligament, pelvic wall, and then the sigmoid and the rectum. So just let's look at medical versus surgical before we jump into the surgical management robotically. Yes, we give painkillers to all the young girls who present with dysmenorrhea. Then we bung them all on the oral contraceptive pill. We used to tricycle the oral contraceptive pill for many, many years until Dynogest came in. GnRH agonists were given and are still being given, and then patients come back feeling absolutely wretched and horrible, and it's the husbands who are generally complaining, saying that we don't recognize this lady anymore. All of these therapies, medical managements, are suppressive. They don't actually cure the disease. And symptoms recur the minute you stop the medical management. So surgery has to be based on the aspirations, symptoms, and it has to be tailor-made for every individual that walks into your clinic. So typically, when you've tried extensive medical management, it's failed, not tolerated, or somebody has walked into your clinic for fertility purposes and you think that I can't do an egg retrieval until I sort out these endometriomas. Someone who has got hydronephrosis and the sequelae of endometriosis spreading laterally, these are the people who merit surgical management. But what we know is that most of us would give a combined therapy. Even if you operate, you may continue them on medical management thereafter, and you will see a higher success rate as against those that have individual management alone. Pain recurrence after surgery is 53% and 44% after medical management, and that is what the meta-analysis shows us where it comes to management of these patients. As elicited in the previous lectures, we have come indeed a very long way from when the first recorded modern medicine laparotomy was done to the Da Vinci system in 2014. And the Da Vinci system is evolving, as you will see in the experience center downstairs. So I will not go into the robotic platform fundamentals because it's already been dealt with. Why robotics for endometriosis? The 3D visualization, the endo-wrist articulation, and especially in deep infiltrating endometriosis, it gives you a solid advantage over doing laparoscopic surgery. And now people are going even further, where we do the hypogastric nerve and the nerve plexus excision, nerve sparing excision, especially with a double bipolar technique. And what we have seen is that this reduces the post-op bladder, rectal, and sexual dysfunction. Of course, nerve-sparing hysterectomies take a longer time, but there are advantages to it. And of course, when there is colorectal involvement, it is extremely important that we use the best technique so that you give the patient the best outcomes post-op. All of these surgeries where deep infiltrating endometriosis is noticed are extremely long surgeries. Imagine having to stand next to the patient with the laparoscope for 3 hours, 4 hours, and operate and getting tired. So robotic surgery offers you the advantage of sitting down and working long hours and having all the forearms under your control. The LaRose trial is the only published RCT where they found that the operative time is comparable between lap as well as robotic assisted. But then you have to look at the case selection, because typically if you are doing complex endometriosis, if you count in the docking time, the OR time and everything, the time definitely is longer with the robotic surgery. But what is important is the quicker recovery time in terms of pain relief and the length of stay in the hospital. That is different in these patients. So full recovery is seen in 86.7% of the patients in the deep infiltrating endometriosis. The length of stay is reduced by a day. And the recurrence is as low as 13%, because we all know that as long as the ovaries are still retained, patients will come back with endometriosis. There will be a recurrence. So the average operating time, 180 minutes. And conversion to laparotomy is in less than 1% of the patients. Those in the audience who deal with fertility in patients with endometriosis, it has been shown that at the end of 3 years, there's a higher pregnancy rate in those that were operated with a robo rather than with the traditional form of surgery, and the recurrence rate was much, much lower, reducing the need for painkillers as well. A few things that are important when you are doing robotic endometriosis, especially when you're dealing with the ovary. The oocytes are all present in the ovarian stroma, and therefore it is extremely important how we handle the ovarian stroma when we excise endometriomas. So the technique of reapproximation of just the ovarian stroma and sparing the ovarian cortex when you suture the ovaries will help you not compromise the AMH levels in these patients and thereby not compromising their fertility. At any point in time, it is very important that you prefer excision or of the cyst wall rather than just simple drainage and ablation of the endometrioma. Where it comes to bowel resection, shaving of the nodule reduces the risk of complication and the recovery rate is much, much faster. There are other scenarios, as I mentioned earlier, where you have ureteric involvement, there are bladder nodules, and there is a frozen pelvis. What is important is you must not let your ego come into the picture. It is always important to have a multidisciplinary approach so that your patient outcomes are absolutely the very best. Coming to the cost implications. The robo is expensive. And therefore, if your hospital wants to invest in a robo, they need to have the capital for the latest technology that is available in the market. And then comes the annual maintenance cost of this instrument, the disposables per case, and therefore the cost per surgery for every patient. Now, how many of you in the audience do benign gynecology? Yes? The thing is, the insurance companies keep sending you letters. Justify, why do you want to do this? Now, it's easier to get funding for cancer than for benign conditions. And therefore, you have to send as many as 4 to 5 letters to the insurance companies because you need to justify the cost of the robotic consumable, the arms, and every single instrument, as Dr. Rubina said in her earlier talk. Every instrument that you use is charged, unlike in laparoscopy, where you have your kit, you can use the harmonic, the ligashore, or whatever you want. But every single instrument, if you use a bipolar, a scissor, and a prograsp, each arm is costing the patient something between 20 to 30,000 rupees, and that gets added on to the cost. And many a times, patients have to pay this from their own pocket. Therefore, counseling every patient, the need for robotic surgery, and the extra cost that they will incur, sometimes not funded by the insurance companies, is extremely important when you take them up for robotic surgery. The learning curve and credentialing. I think this is extremely important. How many cases do you need to do before you can be certified as a robotic surgeon? Anywhere between 20 to 200. In our hospital, we have about 20 cases. But you need, some people may need more, some may need less to reach the proficiency to be able to do this independently. The Mayo Clinic said that you need up to 91 cases to be absolutely proficient in robotic surgery. And currently there are more than 66,000 trainees who have trained on the Da Vinci system. It's extremely important to work many, many hours on the simulator before you can unleash yourself onto the patients. So the limitations, as we elicited in the earlier talks, that there is no tactile sensation, and that is a limitation. Especially, you don't know where you are, And therefore things like, as I said earlier, you can use the ultrasound, you use the ureteric stenting, the ICG dye, so that you can visualize structures better. The longer operative time, and therefore you need to prepare your team for it, and you need to be ready yourself for this kind of long stint surgeries. Cost implications are higher, but robotics definitely adds on benefit in complex and advanced diseases in endometriosis rather than in early stage diseases. So when you have minimal and mild, you can get away with a laparoscopy. You don't need to really do robotic surgery for these patients. So the new frontiers are the single port robotic Da Vinci that will be coming into the market, and hopefully that will bring down the cost implications for the patient. And I would look forward to seeing the system in the near future. As I said earlier, multidisciplinary care is absolutely paramount. Make sure you do your ultrasound and the MRIs in complex cases. Make sure you have an MDT meeting and plan the surgery well before, and then just don't go and operate on the patient on the spur of the moment. Make sure it's properly planned. The British Society of Gynae Endoscopists requires a formal accreditation of the center and the surgeon, and they deem it absolutely essential that two competent surgeons are operating in advanced cases. So a single surgeon cannot deal with it in terms of patient safety. Most importantly, as I said, ultrasound and wherever required, MRI with contrast, and Dr. Santosh is sitting here and I chew his brain all the time for all my patients. And they're extremely helpful in planning the surgery. These are the guidelines that are available across the world from the European Society of Human Reproduction, the Joint Working Group, the American College of Obs and Gynae, and the AAGL. Basically, every single guideline tells us that safety is paramount, planning your surgery is paramount. Surgery is an option only when you have tried everything and you think that surgery will truly offer benefit. So the key takeaways from my talk before I show you the videos is that robotics offers comparable safety outcomes in relation to laparoscopy. A longer operative time, the higher per case cost are the real trade-offs when you do robotic surgery. But the advantages: nerve-sparing surgery, 3D visualization, single port technology, ICG, all of these things give you a huge advantage for endometriosis, especially complex and deep infiltrating. The guideline bodies have not formally endorsed robotics over laparoscopy. That is something that you need to remember. But the next decade will show us more progress, and it will be, more systematic as to how we deploy our training, our teams, and patient selection, and it'll be less about the platform. So the question really is it robotic versus laparoscopy? Are we fighting two technologies with each other? No, it is about what is safe and what will ensure a complete excision for every patient with endometriosis who comes to you. Robotic surgery, please remember, is a tool. It is not a diagnosis-specific default, and the best value appears only when you have a very careful case selection. Surgeon expertise is mandatory, and MDT planning is important. Complete excision. Let your first cut, the first surgery, be the best surgery so that you minimize the risk of recurrence and you give the patient a better quality of life. And that can be done on any platform. I'm extremely grateful to Team Creation, to the robotic OT team in Fortis Hospitals, all the clinicians in the allied specialties who work with me day in and day out, the Fortis management, and most importantly, the organizing committee of SURGX 2026, headed by Professor Mohan Keshav Murthy, Rubina, and everyone. And finally, grateful to all my patients who come to us with a lot of faith and hope to improve their quality of life. Thank you very much for your patient hearing. We'll now see the videos. Rubina, can you? Go back. Yeah. Okay, so this is a patient who came with primary infertility. She had many fibroids as well as endometriosis. So you can see, so we all like a nice endometrioma, right? Where the dissection is nice, easy peasy. But you can see that because you're so close, you can actually excise the cyst wall very beautifully, and every small bleeder can be coagulated with your bipolar, and you can ensure that a complete cystectomy is done, and the base of the cyst wall is coagulated to minimize the risk of recurrence. So I finished the myomectomy in this patient first, and then I went ahead to do the excision of the endometriosis. So this is a quick, short video. Many a times, I do not suture the ovary because it's not required, because sometimes you can make the suturing very tight. And you can see that my assistant with the lap port in the left iliac fossa retrieves the tissue as I'm excising it. So your assistant and you need to be talking to each other continuously. As Rubina said, sometimes you can swear at the assistants also and say, you're not paying attention. Where are you looking? So it's important to remove all the endometriotic tissue so that they do not go and settle down somewhere else and grow endometriosis in other spots. But this is a nice, simple ovarian endometrioma. This is what we like to do every single day, but not all patients are like this. So this patient has had a wonderful recovery. She had about 5-6 myomas, so all were excised. I always put a hemolock. I don't know whether Rubina does that, but I put a hemolock at the end of my suture on the, when I suture the myoma beds, just in case the suture slips out. With the barbed vicryl, the risk of the suture slipping is not as much, but sometimes they do when the cavities are very big. So I just put a hemolock and then I cover the whole thing with an interseed. So the next video is the more complex endometriosis. So this is a patient who's had a young patient, primary infertility, who had one previous surgery for endometriosis. And this is what her pelvis looked like. It was a completely frozen pelvis. Because she had previously surgery, and this time it looked very bad, I decided to do her egg collection, retrieve the eggs, and freeze the embryos first. But you can see this is a completely frozen pelvis. You cannot make out head nor tail of what is there when you go inside, but this is how it looked. Somewhere over there is the uterus in the front, and you can see the bowel, and everything is totally plastered. So it's important to identify the structures and do what you need to do, because this patient needed an embryo transfer, and the hydrosalpinx compromises the pregnancy rates. So I decided to do a salpingectomy. So adhesiolysis done, the tube identified on the right side, and here doing a salpingectomy with the ProGrasp, bipolar, and the scissors. So this surgery took 3 hours, and I've condensed it in about 10 minutes. So I can demonstrate it here. But it needs a lot of patience. And sometimes you just have to keep doing, and you just have to persevere doing what you have to do till you restore anatomy. It's all about trying to get back normalcy in the anatomy, cutting down the amount of inflammatory process that is happening in the pelvis, which can be sperm toxic also, especially in relation to fertility. So that was the ovary with the endometrioma. So we now have the endometriotic cyst wall that is being excised. Anteriorly, the uterus was adherent and so was the bladder. You can see the bowel is totally plastered to the fundus of the uterus, and so is the left adnexa. So you have multiple endometriomas in the left ovary as well. So multiple endometriotic pockets every single place as you go along. So when you do this, sometimes the bipolar doesn't grasp very well and you miss the laparoscopic madrillons. That would give you a better grasp of the cyst wall. So now the left ovary was adherent to the bowel wall as well, the rectosigmoid. So you can see the bladder was anteriorly adherent and we had to separate the bladder from the uterus. And this is pararectal dissection because the rectosigmoid was adherent completely to the left adnexa and we still had endometriomas in the left adnexa which needed to be excised. It's a very bloody field and not the classy videos that you should be showing in a conference, but this is what real world endometriosis looks like. Messy, bloody, adhesions everywhere, and you're constantly looking at tissue, front, back, making sure that you're not cutting out the wrong tissue when you're doing an overzealous dissection. So now there is some space here, but we still have adhesions to the rectosigmoid. That is still the left adnexa adherent, and there is still another cyst there. You can now start seeing the ovarian wall, which we weren't seeing earlier. So you saw those two blue lines coming. So I was talking to the surgeon who was with me, Dr. Shashikiran, and asking him, does this look all right? And he said, yes, this plane looks all right to dissect. So as I said, you need to have another pair of eyes that are looking at what you are doing sometimes, because you can get tired when you do extensively long cases. Another pair of eyes looking at what you are doing is extremely helpful and reassuring. So you can see we're trying to achieve a complete separation of the ovary from the rectosigmoid in this case, and trying to excise the cyst wall. So you can see the anterior wall of the sigmoid still has. This is ICG because you need to know where your friendly neighborhood ureter is. So you turn on the firefly, identify the ureter, make sure that you have dissected clean of it. And this is shaving of the bowel nodule before we wrap up. Almost done. 2 minutes. So as I said earlier, the advantage is you can take a break, you can go for a walk, have a coffee, and come back when you're doing long surgeries. And it's extremely important that you take short breaks because you can get tired when you're doing this kind of surgery. Almost done. Just a little bit of suturing so that all the things don't stick once again. So we've got now some amount of restoration of anatomy. A thorough irrigation is important. And finally, I put in adhesion barriers to minimize the risk of adhesion to the best of our abilities. So that's the interseed being put in. And this patient has been given Lupride at the end of the procedure, and she will be coming in for an embryo transfer because she's got embryos, although not the best quality embryos, but she has day 3 and day 5 embryos awaiting her for transfer. So this will be done in 2 months' time while she's still on the Lupride suppression, because only when they are in the Lupride suppression do you have synchronicity between the ovarian cycle and the endometrial cycle for those of you who are interested in fertility and IVF. Thank you very much for a patient hearing.
Any questions? If there are no questions, I request Mr. Praveen Wali to present a memento to Dr. Manisha Singh. He's a facility director at Fortis Cunningham Road. Sir, I request you to present a memento to Dr. Parimala Devi as well. Ma'am, please take the stage. Now I request Professor Mohan Keshavamurthy, Chairperson of SURGX 2026, to say a few words. Thank you, sir.
Good morning. It's a privilege. Hello, can you hear me? Yeah. The purpose of the CME was to demystify the robotic surgery journey for each one of you who is in the room. When I started 10 years ago, there were not many training programs in India. I had to go to France at -4 degrees to train myself and come back. I was 50. And there was a question whether open surgery I can do in 2 hours. Should I learn to do it through the robot for 8 hours with the hope that at some point I can do the surgery robotically in 2 hours. So for all of you in the room, it took us as a team. We are the largest private sector urology team in India. I have 30 colleagues, smarter, better qualified than me. The only reason I get to lead is because I'm the oldest. The point of addressing you was that for each of you who want to do the robotic journey, it's much simpler to do it in India today. I have at least in the room 10 people I've mentored through their journey, including Dr. Rubina. Dr. Prakruti is the youngest robot controlled surgeon in India, whether it's a gynecologist or a general surgeon or urologist. The journey starts with your willingness to learn something new in exchange for something you've already been trained for. That's the only journey mentally that you have to do. So it took us 53 months for our first 500, interrupted by the COVID epidemic. It took us 30 months for the next 500. It took 17 months for the next 1,000. It took us 12 months for the next 1,000. And we'll do 1,500 in the next 10 months. So we started off with 1 robot. We have now 3 robots in the city. We are the only facility at Banagata in the south of the country to have 2 robots side by side. We are the only program in Asia to do both donor and recipient simultaneously on 2 Da Vinci Xis and side-by-side OTs. We are actually the only hospital amongst 92 hospitals IHH worldwide capable of doing a robotic kidney transplant. The reason for mentioning all this is not about how good we are. It's to inspire you to what you would want to be. We have multiple training programs. We have a niche urogynec program where urology and gynecology meet. Urologist meets gynecologist only when there's a hole in an inadvertent place, when you're trying to do a difficult procedure or you're doing the procedure in the learning curve part of it. 12 years ago, I was on the podium with Dr. Devi Shetty addressing the National Gynecology OBG conference, and he said, for those of you who are OBG in the room, if you don't learn robotic surgery, the G will run away and you'll be left just with the OB. I'll repeat that 12 years later. The way forward is minimal invasive, whether it's lap or robot is a choice, but both are complementary, as Dr. Manisha said. You also have a natural orifice to get the tissue out. Tomorrow, Dr. Punya will show wonderfully elegant morcellation techniques to get large gynecological tissue out through small or minimally invasive for maximal comfort. That will be her topic tomorrow. For those of you who would want to do this journey, I would request you to communicate with one member of the team. Each of you would have, you are at different age groups, different technical ability, different locations where you're going to practice. Not all of you will be in corporate hospitals. You might be a single individual driven setup or a nursing home setup. We should be able to energize each person's individual journey, tailor-made to what you want to be and what you can afford in your own particular hospital ecosystem. So one of the reasons I interrupted this brilliant gynecological session was to say that although we are urology, we are a dominant robotic program in the country. And I have had the privilege of mentoring cardiac surgeons through robotic surgery. I had minimal access surgeons into robotic surgery, had gynecologists, urologists, and bariatric surgeons to do robotic surgery. So robotic surgery is an independent vertical, and I see in the next 3 years an MCH in robotic surgery, like it's already there in the country now, MCH for minimal access surgery. And this year we have a FMB, a post-MCH 2-year program in minimal access robotic surgery and kidney transplant surgery. So we are evolving into small areas. So for all of you in the room, please communicate with one member of the team of how we can energize your individual robotic journey. It's a pleasure to have you all. Collaboration, exchange of ideas, which should make each one of us in the room a little better tomorrow than we were today. Thank you.
Thank you, sir, for the talk. I now request Dr. Rubina for the next talk. I've already introduced her, and she requires no further introduction. Ma'am, please come up on stage.
Thank you, sir. Thank you for the lovely, inspiring words. So now we'll move to the next part. Robotic for pelvic floor reconstruction. Again, like sir keeps saying, an elegant the apical repair. We have a whole session on apical repair tomorrow morning. If you can, so this I am going mainly into, since this is more a technical CME, I'm going more into the techniques of how we do the pelvic floor reconstruction. Tomorrow would be case-based scenario. When would you choose what? So this is, yeah. Yes, so in urogynecology, robot again has been a blessing. Yes, I don't, when something is coming out, why do you want to go up and take it out? Is a common question we gynecologists ask themselves. We are all primarily vaginal surgeons. Then only we decided to adopt the abdomen also as a port of entry. So vaginally, it's again goes to case selection. So vaginally, if you think this patient's native tissue is good, and depends on the stage of prolapse, depends on the recurrence of the prolapse, and depends on the age of the patient, main importantly, is how we decide the route of surgery. And so I'm not here to go into those details today. What are the robotic procedures we do for the pelvic floor? I'll run you through those. Here, if you see, so these are the two apical suspension procedures which we do. So what do I mean? I mean, I'm sure all of you know the stages of prolapse and the compartments. Most important for anyone is to know that after we do a hysterectomy, please do suspend the apex. As a urogynecologist, it's my request that do something. At least bring the uterosacrals and attach it to the vault. Because if you don't suspend the apex, you're giving me business. You're giving vault prolapse. So please always suspend the apex. And these two procedures, so in urogynecology, this is our main what we do. Apart from this, today what I'm not covering, I'll tell you, is fistulas, is ileal neovagina, all of which will be discussed tomorrow. I think Prakriti is showing a small video of ileal neovagina, but these two are the mesh-based repairs. Now, what are the procedures for apical repair which we have? We use either the sacrospinous ligament. You can access only vaginally. Doesn't make sense to do it from the abdomen. You have uterosacral ligament. Which portion of the uterosacral ligament we use? High uterosacral ligament is ideal. Again, vaginally is what we use the uterosacral ligament suspension. And now we have started doing HUSL. Dr. Prakriti has gotten trained in V-notes, and it's making a huge difference. Beautifully, we are able to see the ureter and take the high uterosacral ligaments stitched through V-notes. So these are the vaginal parts. Coming to the abdomen, mesh. When will I choose a mesh repair? This is a patient who is apical prolapse is stage 2 or more, stage 3 prolapse, young patient for whom you think if like around 50s who need some kind of apical suspension. And when there is all three compartments descending, then we need mesh reinforcement. Another major pointing factor in the history is she's had a prior mesh repair done for hernia, which means intrinsically her tissues are deficient and lax. So you can't depend on the native tissue. All these are where we use the mesh. Sacrocolpopexy, all of us have learned this as a long answer question in PG. So, when I was doing PG also, it was a huge, big incision. Only the head of the unit used to do it. Assistants would stand on the side and say something is happening. So now with robot, everyone is able to see what is happening and do. I take pride in saying that every member of our team can do it equally efficiently. No one is better than the other, and technology has leveled that out. So here it's a long established gold standard, but what are the drawbacks of sacrocolpopexy? I mean, not drawbacks, challenges. You need to go in the presacral area. So you need your anatomy proper. It can be technically demanding in obese patients, and if they have been operated for endo earlier, or they have multiple adhesions for whatever reason. And there's a little injury of, risk of ureteral injury if you're not careful. But long-term studies are there. 1991 was when it was started, so we have enough long-term evidence that very low risk of recurrence. Pectopexy has only recently started. I'll move on to pectopexy. Yeah. So this was in 2007 that when they first decided to try this. Now, as you know, where is the pectineal ligament? We all know. So general surgeons are very, it's called the lighthouse sign. It's where they fix their hernia meshes also. So this, where we suture, like the medial part where we suture is what we use for Bush colposuspension. The lateral part where we suture is what we use for the Cooper's ligament, that is a pectopexy. Now, this has been adopted over time. For which patient will I choose a pectopexy? Especially if I'm conserving the uterus, if it is more of an anterior compartment, she has a cystocele and she has an apical prolapse, then I prefer a pectopexy. As I told you earlier also, if it's a universal prolapse, then it's more of sacrocolpo because the whole thing comes down and it's a natural vaginal axis. Even this is up to S2 level. So that's where the internal os is. So that's more than enough as well. And apical prolapse, combined dissection, prior pelvic surgery, where you have gone in, and as I run through, I think I'll go it, otherwise we'll run short of time. Contraindication, if the patient is sensitive or allergic to mesh, don't use. Pregnancy, highly debatable, because obviously if the pressure of the child is going to come, then the mesh is going to go loose. So they can't become pregnant again, but yes, we can preserve the uterus for sure. And of course, malignancy. Then there's no point in preserving the organs. Relative contraindication, again, depends on how good your anesthesia team is. We are blessed with excellent anesthetists. So any cardiopulmonary risk we can take, whatever Trendelenburg, they'll give it to us. But the patient also sometimes, the patients who have come from NHS country, this is the season for them to come. They'll come down from Australia, Canada, and they would have been advised there, but they can't meet a urogynecologist that fast. They'll come, would have read everything, and they'll say, if you put a mesh, I can't do my follow-up there. So do some non-mesh surgery. Then we can't go for this. So all those are challenges which you'll have to individualize. So the key surgical anatomy, again, I'll show you as I walk through it. The Cooper's ligament, external iliac vessel, obturator nerve and vessel, and the corona mortis. All these four, if you know where they come, then you can go. Because the beauty of urogynecology is you need to know your spaces. And in those spaces, hardly any blood loss will happen. So if blood loss happens, it means you have hit something you were not supposed to hit. And so these are what you have to identify. The complications, again, I'll go through the video first. Yeah, so this is a video of a colpopectopexy. Most of them will have adhesions. It is prior surgery, right? So all this, again, the robot helps. You have to go deep down. This is, again, if you think this patient will benefit from a vaginal procedure, little older patient, then please go ahead with vaginal. But if it's, like I told you, the other indications, then because you have to walk through the entire bowel till you reach the area you have to reach. Now, here we are at the vault level. So at the vault level, once I finish separating off the bowel adhesions, identifying which is the bladder, which is the rectum is the main important. And taking adequate thickness of the vagina, because if you take too thin, mesh erosion. So here you can see that we are, so again it's all visualization. As you do, you'll get to know what looks like bladder, what looks like vagina. It's very easy to go into the bladder because it's falling out like that. And even if you can try using an ICG dye. But if you give a lot of time, then even the normal vasculature will take up the ICG. So here this initial incision is very, very important. So once, what we have inside is something called a sacrocolpopexy tip. It's nothing but a cylindrical instrument which we attach to the Rumi manipulator and we use it to push because all these tissues are lax. You don't give adequate traction, counter traction, you will not see the tissue. That is the primary rule of all these surgeries which happen in the spaces. So now you see the vagina has actually been delineated and then we go a little higher. So what is your limit of dissection? If you see, 1 second, yeah, there. So the bladder is on top. The bipolar on the left is holding the bladder up. The scissor is cutting it. Always, fat belongs to the bladder. Go under the fat. Go on the vagina. Initially, when you have the pubourethral ligament, is when it will, you'll think it is stuck, adhered. No, it's a ligament. You have to cut it. Unless you cut it, you can't go beyond it. And once you've crossed the ligament, then it's easy to go in. Now we are using a 30 down, but once we have an adequate, as you see, once a little dissection, assistant pushes further. So it has to be a coordinated effort between the surgeon console and the vaginal assistant. And as we go, what is your limit of dissection? Is bladder neck. You know, even in vaginal surgery, bladder neck is our limit. Don't go beyond the bladder neck. You'll go and cause unnecessary issues. So how do we know the bladder neck when we are going intra-abdominally? Ask your vaginal assistant to just move the Foley's bulb. So, and you go, like, you come out. So again, this camera, it's very easy to zoom in and zoom out. You zoom out, you see a panorama, you'll see the bulb there. Go under the bulb, that is your anterior limit. Here we are going now for the pectineal ligament. What are your landmarks? The round, when the uterus is there, it's very easy. In the absence of the uterus, you have the medial umbilical ligament, you have the external iliac there laterally, and you have the round ligament. So use this space, expose it, you know, cut properly as much of the peritoneum as you want. Because if I go too medially, I'm not, yeah, you can see my arrow, I hope. If I go too medially, here is where my external iliac is. If I go up here, onto the anterior abdominal wall, that's where the corona mortis is. And if I go in this direction, deep down here, then I have the ureter, this is the bladder. So I just come in, go out, come in, go out, zoom in, zoom out, and once you see there, you can see that green line, that's where the pectineal ligament is. So once you know the anatomy, initial couple of cases you might kind of find it thing, but always keep your landmarks in mind, keep telling yourself, advantage of robot, stop, open ChatGPT, see the landmark, come and correlate. That will help you, but not all the time it also doesn't help. But so know your anatomy. So here, once you reach here, again, please expose an adequate length of the ligament. You need the mesh to sit properly. So what we now need to do is, this is the, you know, the peritoneum, the broad ligament. And so we have to go under this to cover the mesh. You have two options. One, you tunnel. You can't tunnel, open it up, because suturing is easy. You can always suture back the peritoneum. So whatever you're comfortable with. So here you can see that we have tried tunneling. If it's not possible from that side, you try from the other side. So push the fat away, go right under the peritoneum. You're hearing two talks at one time. I'm sorry for the people at the back. I think that's interfering. Dr. Karthik's voice always carries, without a mic also. Yeah. So yeah, here, that's where we come out, and then, so we are tunneling and keeping it ready. So this is the tunnel with which we go. Now comes the mesh which we put in. So this is the mesh which is used. You can, ideal is bilateral, but in, you know, an elderly lady, if you're short on time, unilateral is also okay. So you suture it on, like I told you, for anterior compartment. It's very useful. And if you think it's global, you can even take the mesh at the back. So you have to design the mesh and then use it. Suturing, again, it's such a blessing to suture with the robot. So wherever you want, you can go, however, vertically, horizontally, however you want, you can suture. And what we use is a lightweight, I mean, standards of surgery remain the same. Lightweight, macroporous, type 1 polypropylene mesh. Never use any other mesh. Fashion it according to how much you have dissected. Always non-absorbable sutures, never use absorbable for fixing the mesh. And make sure you haven't taken too less or too much of the vagina, because you're doing this in a sexually active woman. So that you have to be careful about. So this is the sutures which are placed. Sometimes it, yeah, so this is the whole suturing, and you don't have to take, because it's so easy, we keep on taking, not realizing that time is also this. You just take enough to anchor. 3 is more than enough. 1, 2, 3, triangulate and take it out. So this is one. I wanted to show you another one where we have, yeah, so this is cervical. This again is that recording system. So it is that jerky movement which is not supposed to be there. So here we are preserving the uterus in this patient, young lady. So for her, here again, we are first going in the lateral, identifying the pec. Here again, you can see it clearly, the external iliac. You see the bluish structure on the left, that's the external iliac. You can see, if in thin patients, it's easier. So always initial patients, try thin patients before you go in for obese patients. There you can identify the mesh, I'm sorry, the ligament, the Cooper's, the lighthouse sign. It will just shine for you. There. So that's your lighthouse sign. we are doing a bilateral in this patient. So I'll show you the appearance. Yeah, so this is on the right side. You can just see the external iliac. If it's on the right, it's the right side. So this is the right hand. Now you can, I come out. And if so I'll just pause the video for a sec. Yeah. So here, if I go a little more medial, then that is Bush in front. Where I'm going, yeah, this is lateral. You can see both have been picked up. You can see both the white structures. So this is where we are going to anchor. The rest again, like I told you, when the uterus is there, it's very easy to identify and go in the planes. In the absence of uterus, it's a little more challenging. So here, go beyond the cervix, go down. Again, the same has to be you can't just take a little bit of the vagina and say, I'm done. Then you'll end up with, the patient will still have that lax vagina. She'll keep complaining there's something still there. So go right up to the bladder neck and suture the mesh. So this you can see how beautifully it's come up. Yeah, and then we are doing the mesh suturing. This is that what you read about, right? The head-shaped or the T-shaped mesh. So this goes here, the arms go there, and just enough traction so that don't give over traction. That's more important in vault prolapse. The patient will come with de novo urgency. So that's also something which we have to look into. Here you can see. And then the last step. So this is again, it's your preference what you want to use on the ligament. Either you take a stitch or you can use a non-absorbable tacker also. Because this is important. If after doing all this, your stitch is loose and it gives way, no point in doing everything. So we always prefer, I mean, especially when we do at the sacral level, we always take a tacker. Better to be safe than sorry, along with the suture just to kind of make it sit in the hollow. I'll show it to you when we go to the sacral end. So this is the mesh for cervical. I'll just run through this video. And I was just telling someone here that in any surgery where we are putting mesh, we are sure they are done with childbearing. As part of our uterus preserving, not fertility preserving, uterus preserving procedures, always pre-op, we do a PAP, we do an endobiopsy, and we do an opportunistic bilateral salpingectomy. Because on the recommendation of our resident Gynae onco expert, Dr. Punya, 90% of cancers of the CA ovary come from tube. So anyway, the tube has no function, take it out. So with all this, you're also satisfied in keeping the uterus back. Because even for a 70-year-old, we have done this. She only had a anterior compartment prolapse. Why to take out the uterus? It was like an atrophic uterus and it helped us with the traction. So we just left it behind and we did all the other repairs for her. So this is, yeah. And then last step, always reperitonize. Your mesh should not get exposed because that will lead to bowel adhesions. And then moving on to the gold standard, sacrocolpopexy. So there are enough meta-analysis to show you that it is equivalent to the vaginal approach for pelvic organ prolapse. And in conclusion, you definitely have a reduced blood loss compared with vaginal surgery and hospital stay. 1 day. 1 day is all we keep them. That also for safety sake, for insurance reason. Otherwise, same day also we can discharge them. This is how the ports look. We have a standard either, only in myoma does it vary. Otherwise, it's usually at the umbilical level. We go in a straight line. Sometimes in onco, when we are doing para-aortic or when we do myoma, that's when we try and alter our ports a little bit based on the size, what we need to do. Otherwise, this is our standard port placement. So sacrocolpopexy, here you can see that we are going at the sacrum level. The headache is handling the bowels because most of them will be old. Anesthetist will say tidal volume, is not getting maintained. You please can't give you that much Trendelenburg. Reduce the intra-abdominal pressure. So all these are techniques to keep the bowel away. We take this to the mesentery, anchor it. So we, move the bowel away everywhere. And this you can see a cobbler's needle is coming in through the left. And then we take this bowel which we have anchored and keep it on the side because you are wasting instruments otherwise trying to keep the bowel away. So you keep the rectosigmoid away, you keep the small bowel away, then you go into where otherwise every step you'll have to use all your instruments just to handle the bowel. If it's too cumbersome, patient is having anesthetic issues, go and finish off with the pectopexy. You're still doing an apical repair. So that's where pectopexy usually works. Here, yes, we are at the sacral level. Always identify the ureter. And you can see the ureter on the right. And you can see the, where are we here? Yeah, huh. And then we go down we are tunneling in the presacral area. So here you'll have the common iliac if you go too high. You have the ureter laterally, and medially you have the hypogastric nerve plexus. So if you injure the hypogastric nerve plexus is when you get the constipation, which was a common side effect which we used to learn with sacrocolpopexy, but these days with the robotic vision you're able to avoid it and go down. And again you can see the ureter, it will peristaltize, the peristalsis will be seen very nicely on the right side. So once this is done, another step which helps is giving a little tilt prior to docking. So then the bowel moves to the left side, left down, right up. So that also helps in these patients, but your orientation should be fine. You should know what you have done because your pelvis also tilts. So that's where the yellow fin which Dr. Prakriti was talking about makes a big difference, because you have to tilt the pelvis as per, accordingly everything will move. So your orientation has to be correct. So now we have entered the presacral space. We are trying to go down. See there, we can just go under the peritoneum and come out. We keep an eye on the ureter and go medial to it, go down right up to the space where your mesh will come. Now the vaginal assistant is pushing up the sacrocolpopexy tip. You can see how the vault is coming up and the bladder is sitting in front. So in these kind of patients it's easy to delineate, but in a lot of them when doing VH they would have stitched together even the round ligament, the tube, so you get confused which is what. So you'll have to separate all that when you get to the vault. Here you have the vault, and how many minutes? 30 more seconds, okay. So this is the anterior. Again, the principles of dissection at the vaginal end remain the same. Go completely down, don't, and in the posterior. So here, the rectal, there's a lot of varying techniques which are used when you go in the rectovaginal fascia. So some people use a Y-shaped mesh. They go and they take up the levator ani, but it causes so much pain to the patient. So if you think about it, when we do vaginal surgeries, what we are doing, the perineorrhaphy is the superficial perineal muscles. We don't go up to the levator ani. And here we do the vault. So you don't have to, even in a global descent, you don't have to do the levator ani. Just go deep into the rectovaginal space, anchor the posterior. So you cut the mesh accordingly, Y-shaped mesh. And there you can see the initial stitch is always the toughest because you have to go deep in and place. So that takes a little time. Once it's anchored, it's easy to do the rest of the surgery. So here you can see we have gone right up to the bottom suburethral level in the vagina. We just take 3 more stitches. And then this is posterior. This, what we do next step, we have already made the tunnel and kept. So at that tunnel, again here, keep a count of the needles you use. We usually just keep anchoring it inside. We don't, want to waste time taking in and out. The needle count is maintained by your scrub nurse, who will then tell you how many you have to take out in the end. So yes, so this is done. And yeah, so this is the tunneling step where we go in, pull the long arm of the Y back, and that I'll just show you quickly since we are a little short of time. Yeah, so this is taken back. And this is sutured. So this traction is very important. Mesh traction. Your assistant at the vaginal end should tell you how much you need to traction. Never too tight, never too loose. Too tight, de novo urgency, it will never go and they won't leave you. So you'll have to kind of keep that in mind. And in case you do hit, how do you avoid the middle sacral vessels? Stay to the right. Don't go right in the midline when you're taking the stitch. If you do happen to hit, just give pressure 3 minutes by the clock. It will stop. If not, use your bipolar. It's not that complicated. Hypogastric, you won't know intraoperatively. Only post-op with constipation will settle with time. Give it 3 months, put them on a stool softener, will settle. And then the other ureter injury, you have to pick it up here. Or you will have a fistula later. So this is where we take, like I was telling you, this is the stitch. I think in this we also have the, okay, it's not in this. The next video, the tacker, which we use. I wanted to show you the tacker. Yeah, this is a sacrohysteropexy, where we kept the uterus. Again, I'll just move to the last. So this you can see, we are going around the cervix. You open the broad ligament, leave the uterine, the space which you have in the lateral, open that. Hug the uterus in the pericervical region. There you can see our scissor coming out. And then making the space for the dissection. all this is the dissection being done. Yeah, so yeah, here comes the mesh. So the mesh is too short for us to kind of, do the entire thing with one mesh. So we use one to circle around, and then the second mesh is just one straight mesh, which will attach to this circular one and pull it back to the sacrum. So this is with sacrocervico or sacrohysteropexy. There, you can see. So this is sutured on. And then this is the suture which is taken at the sacral level. So the suture helps it sit in the hollow. It doesn't like stand like that with tension. And then the tacker should have come in here. Okay. So the tacker is nothing. It's just a device which you need to press and it releases a screw kind of thing. And that keeps it anchored at that level. So once this is done, you can see the uterus which was floppy is now stable. And the last step, always reperitonize. Don't leave any part of the mesh exposed. That will lead to adhesions again. Yes, so this is how we do a sacrohysteropexy. Yeah, so what do the various guidelines say with regard to uterus preservation? It's always been our dilemma. Ultimately, they all say individualize. Nobody is giving us any clear-cut answers. So it depends on what you think about the patient. If it is a apical prolapse where the uterus is coming, the only reason you're preserving uterus is for support. If that's not there, then what's the point? So then counsel them again for uterus removal. But if it is everything else, cystocele, rectocele, but no apical prolapse, leave the uterus back, correct everything. So that's the general dictum we follow. And there are some patients who, for their own cultural and religious reasons, don't want to take out the uterus. For them, again, counsel and keep it back with the chances of recurrence. Never use native tissue if there is a apical uterine prolapse. It won't help for them. Okay, so basically avoid middle sacral vein, hypogastric nerve preservation, correct mesh tensioning, bladder injury, very common. It's very easy to mistake the bladder for the vagina. So you have to, as you do, you'll know the orientation, how it looks. The bladder basal detrusor looks very similar to vagina. So that we have to be careful about. Any doubt, any time, stop, fill bladder, put ICG if you want, use all your techniques and avoid bladder injury. If in doubt, even post, you can put a cystoscopy before you undock and switch off the robot. See if there is any thread seen. The minute if you put in the bladder, you see blood in the bladder, you have done something wrong. Something is coming somewhere. So take out, just cut off the mesh, that stitch which is taken, and leave it alone. You'll be fine. Leave the catheter for a week. They'll settle. And prevent constipation. Trim the excess mesh. Suture selection is very, very important. So this is again evidence-based studies which show it all depends on the surgeon's training. Whichever system they can handle best is the ideal system for the patient. Thank you very much. Thank you all for your patience.
Any questions?
Not so much, ma'am, but we have seen mesh erosions. So then we usually give them topical estrogen therapy. With that, it settles the mesh erosion.
Any other questions?
Of that we have to tailor, ma'am. Usually it's 3 centimeter, the width, which we have this thing. And then the length can vary anywhere from 11 centimeters to it can be as short as 7 also. Yes, so we have to cut. So after our dissection, the assistant who's sitting at that patient console will tailor it and bring it in. 15 is enough, ma'am. You can take that standard Ethicon mesh of 15 into 7. That should be more than enough. It won't go more than that. Once you give the traction, you'll actually have to cut off the excess mesh. That if you hit the bone, you have gone too deep. The ligament is a thick ligament, ma'am. It gives, yes. So you have enough space. So there is no, so basically around somewhere to quarter to half of the needle depth. Like if it goes in, that's your right thing. And you'll feel, if it's hitting the bone, come out, go little superficial. That's why tacker, safety, initial few things. Once you know what is your depth, then let go of the tacker, just rely on your sutures. It doesn't go maximum, it goes up to 1 centimeter. It's like one screw of the myoma screw which we have. It's one screw, that's all. Yeah.
Thank you, ma'am. Now let's come to the few questions again before the next talk. What has a neck but no head? This is not related to anything robotic or gynecological. What has a neck but no head? A bottle. The only planet that rotates clockwise. Any idea? Sorry? Yes, ma'am is right. How many hearts does an octopus have? That's right. And the next one is pretty easy. The largest organ in human body. Correct. Okay. Coming to the next talk, I would like to introduce Dr. Punyashri, consultant gynecologic oncosurgeon, Fortis Hospitals, Bengaluru. She specializes in minimally invasive and robotic surgeries for gynecological cancers with expertise in ovarian, cervical, endometrial, vulval and gestational trophoblastic cancers, as well as cancer prevention and screening. She has been trained at leading institutions including JSS Medical College, MS Ramaya and Kidwai Memorial Institute of Oncology. She has honed her skills through fellowships in minimally invasive surgeries and robotic surgeries. An accomplished clinician, researcher and educator, Dr. Punyashri has presented at national and international conferences and serves in several professional committees. Please join me in welcoming Dr. Punyashri.
Good morning, everybody. I would really like to thank Mohan sir and Rubina ma'am and my entire team for giving me this opportunity. So my topic for today is robotics in gynae-onc, the Oncobot advantage. Before jumping into the topic, I'd like to ask you all a question. What is your best learning mistake and what did it teach you? Anybody wants to answer? What is your best learning mistake and what did it teach you in your career? Yes. Anybody else? Okay. So I'd like to share my learning mistake and what it taught me. I'll just let you know. So this is the evolution of surgical procedures. We have open surgeries, moved to laparoscopy, and now we're doing robotics. So this was the incision I used to make as an oncosurgeon. This was the vision I used to get. This was the closure. And this is what used to come up after a week or so. But this is what we usually see outside, right? But this is what we see inside after giving such a huge incision, after doing those complex surgeries. So my best learning mistake is that I always thought I loved open surgeries, and open surgery gives the best vision, the best access to organs, and probably the best oncological outcomes as well. That was something which I've always thought. But after learning minimal invasive techniques and the outcomes which are so good and equal to the laparotomies, so I feel what I used to think was not the right thing. So of course doing a laparotomy was my comfort zone, but a minimal invasive is something which gives a lot of comfort to the patient. So probably I was a disease-based surgeon, now I am a patient-oriented surgeon. So that's my learning from this mistake that I had always thought was, the best. But does that mean I don't like doing open surgeries? I still love doing open surgeries. I'll be waiting for a chance as to when we do open surgeries, because we do a lot of minimal invasive surgeries in our team. So it's like cherry on the top, and I get it maybe once in 2 weeks or so. Yeah. So coming to the topic, the key challenges in oncology are a lot. So there's the disease itself, there's psychological, economical, financial, social stigmas around the disease, a lot, right? Physical, psychological, all of it. So apart from that, there are a few pre-op challenges that we'll have to go through. That is the patient condition and optimization. So physical fragility based on the age, cachexia, malnourished, weakened immune systems, previous treatments they would have undergone, prior surgeries or chemo, radiations, and these can also impair the organ functions and immunity and wound healing. And most of these patients are old and they would have had multiple comorbidities. Intra-op challenges are the complexity of the disease itself and the technical difficulty. So the surgical complexity depends on the extent of the disease burden. Sometimes it needs cytoreductive surgeries, resections, lymph node dissections, and there are compromised tissues, greater tissue disruption, risk of injuries is more, and because of the altered anatomy and the disease itself. So it definitely takes longer operative hours. The highest I've stood was 18 hours for a cytoreductive surgery at Kidwai when I was getting trained. And of course, that's really, really stressful physically, mentally. So higher physiological stress to the patient, higher physical stress to the surgeon. So the post-op challenges are higher rates of infection, there's wound failure, burst abdomens that we've seen, a lot of pain, delayed functional recovery, and complications like thromboembolisms, fistulas, respiratory cardiovascular distress, post-nutritional status, organ dysfunction, metabolic issues, psychological, so a lot, the list just goes on. So these are the challenges that we face in oncological patients compared to the benign patients, right? So the robotic surgery has emerged as a transformative force in this field of gynec oncology, offering a minimally invasive yet a versatile approach to managing a wide range of complex complex gynecological cancers. So by gynec cancers, I mean all of these: the uterine, ovarian, endometrial, tubo-ovarian, cervical, vaginal, vulval, all of these, and of course the GTN. So in endometrial cancers, the gold standard approach is the minimal invasive surgeries. Of course, it could be laparoscopy or robotics, but robotics has an increasingly preferred approach for surgical staging. So we do all kinds of radical hysterectomies, from the modified radical to nerve-sparing radical type A, B, C, C1, C2, all of it based on what the patient needs. So it is completely tailor-made for each patient. And we also do the sentinel lymph node biopsy using the ICG and the Firefly technique, that is technology that is available with the robotics. The lymph node dissections, there are 4 levels of lymph node dissections. The 1 and 2 is a pelvic lymph node dissection, and the 2 and 3 and 4 are the para-aortic lymph node dissections. We go up to the left renal vein and completely clear off all the nodal disease to get the exact staging. So this is a small video. I'm sorry, the video quality is quite poor. This is a small video about the pelvic lymph node dissection. We see it's been done. You see the external iliac vein and the artery, the ureters. So that's the ureter. I've marked it for you. This is the internal iliac artery and the external iliac vein. So level 1 lymph node is the pelvic lymph nodes, that is the external iliac group of lymph nodes and the obturator group of lymph nodes. So the distal most extent is the Of course, what madam said was till the corona mortis we should not go. So the circumflex iliac is the lowermost extent. On the lateral is the genitofemoral nerve. On the medial is the internal iliac or the obliterated umbilical artery. And this forms the level 1 lymph node, which includes the external iliac as well as the obturator group. The level 2 lymph node dissection is the common iliac lymph node dissection. The level up to the bifurcation of aorta. The level 3 level of lymph node dissection is from the bifurcation to the inferior mesenteric artery. Above the inferior mesenteric artery to the left renal vein, crossing over of the left renal vein, is the level 4 group of lymph node dissection. So that completes the lymph node dissections of both pelvic and para-aortic group. So sorry, I couldn't get the para-aortic lymph node dissection, but this was a clearance that we did after robotic para-aortic lymph node dissection. You can see the capillaries actually supplying the aorta. It's beautifully seen. So this is a firefly or the ICG, a firefly technique wherein we use the indocyanine green, right? So what happens is the ICG is injected either into the bloodstream or into the cervix itself at various positions. So this one binds to the albumin in the blood. Albumin is a protein, so it's a protein binder. And when we use the laser light source, the signal will fluoresce. So that is what is seen as the green color. So in this picture, on the left picture, we're seeing the ureter. On the right side is the picture showing a sentinel lymph node, which has taken up the ICG dye. So coming to the cervical cancer, after the LACC trial, it was said that minimal invasive approach is not a good approach to do cervical cancers, not a good approach to do a radical hysterectomy for cervical cancers. So why was that? Because the disease-free interval and the overall survival was reduced with those in the group, who underwent a minimal invasive approach. So recently there are ongoing studies which are working on minimal invasive approach in early stage cancers, so with modifications. So the study includes all of those patients who have had a uterine manipulator being used, which was kind of the source wherein the spillage happened. So now the modifications, various modifications that we use are first doing colpotomy, and then bagging of the tumor into the colpotomy, or suturing the cervix itself, the anterior and posterior lips you suture together so that it's contained. And sometimes, because in open surgeries we have Wertheim clamps, so we dissect up to 2 centimeter from the fornix and apply the Wertheim clamp so that it doesn't come out. But in minimal invasive, the pneumoperitoneum is used. That will cause the spillage, wherein cells from the vagina come into the abdominal cavity. So there are various ways wherein we also have tried using the tags after getting them ETO'd. After dissecting 2 centimeter from the fornix, we just wrap it around the vagina and then do the colpotomy under it, so that there is no spillage. So robotic surgery.
Yes. Really sorry, Dr. to interrupt you. There is a press conference which we have to go for, so I would like to honor our dignitaries who have flown down all the way from Malaysia here. We have Ms. Kim Ling, CEO, Island Hospital. Please join us on the dais here, ma'am. And Dr. Lisa Maria, Medical Head and Quality, IHH Global. Thank you so much for coming here. And we would like to,
I request Dr. Raju, Dr. Punya, Dr. Rubina, and Dr. Prakriti to present the mementos.
sorry to interrupt.
we were talking about robotics in cervical cancer. So, of course, we are doing it in early stage cancers, the stage A disease, that is the microscopic diseases, and also stage 1B1 up to 1B2. Anything less than 2 centimeter can be operated robotically or through another minimally invasive approach. So post-radiation therapy, most of these patients would have had radiation, and there would be a residual disease, a lot of fibrosis. It's so difficult to, kind of dissect all these tissues post-radiation, and even after a laparotomy, the skin wound wouldn't heal. So through robotics, that's a problem we do not have at all, because we do not give a midline vertical incision. And we also, it is during pelvic excentrations, anterior, posterior, or total excentrations, robotic has helped us in visualizing all the organs so beautifully. And of course, we do the fertility sparing surgeries also, robotic trachelectomy, SLN mapping, and we have achieved around 67% pregnancy rate after the fertility sparing surgeries. In ovarian cancers, the robotics is less defined. Not only robotics, any minimal invasive, especially in the advanced stages and high burden disease. But there are ongoing studies which explore early stage, limited disease burden, post NACT for an interval debulking surgery, which have had a beautiful response to chemotherapy, fertility sparing surgeries, and risk reducing surgeries. So risk reducing surgeries are the ones which we offer to patients who have had multiple family members with cancers with a lot of genetic mutations. So for all our ovarian malignancy patients, we do genetic testing. We do the entire panel and check if they have any mutations. And we also screen the family members for those mutations, so that they do not go through the entire panel of testing. So that's how we screen the entire family as well, and keep them as well in follow-up, and offer for risk-reducing surgeries like hysterectomies or BSOs or even mastectomies to those patients who are at risk and with significant mutation. So coming to the upper abdomen, so with the XI system, the entire boom rotates. If you go to the experience center, there is the XI system, a Da Vinci XI robot that is there. So wherein the entire beam rotates. So that's how you can access the upper abdomen with the same ports that you've used for the pelvis. So this is a patient undergoing omentectomy. So as oncosurgeons, we are so used to using the monopolar handheld cautery, right? The pen cautery. So robotics also has the monopolar hook and the cautery, so which can be used. So you can see that in this, we can go up to the splenic hilum, do a total omentectomy, and what you can see is that there is absolutely no blood loss. So with open omentectomy, we use multiple arteries and clamps, and we're using silk, all of that. But here, up to the splenic hilum, we have seen that there is no blood loss at all. It's just the method, the traction, counter traction. You see that one of the momentum is just held up and it is static because it is through the third arm. Whereas this particular bowel is being just used for traction, and it can be seamlessly done with the robotic approach. So there is also inguinal lymph node dissection. We call it as the wheel, which is done robotically. It is still not many centers do it, so we've been just trying it out. So our number of cases that we have done is not much, but we'll get there. As to why robotic. Why not laparoscopy? Laparoscopy is also a minimal invasive approach, and it has 5 mm, not even any 8 mm incision. So why not lap but robotics? So these are the differences that we have between lap and robotics. So in laparoscopy, the scope of the vision, of course, is assistant driven, but in robotics, the surgeon controls the camera, which is the biggest advantage. And dependence always on the assistant surgeon for everything, where here if you have 3 arms, it limits the dependence on the assistant. Lap has a longer learning curve, and 3 individuals have to learn it. who the surgeon should know, the assistant should know, also the sister should know, because she sometimes is holding the camera. So 3 people have to learn what about laparoscopy, right? But here it is a shorter learning curve, and at least if 2 people know, that is good enough. So operator tremors, of course there is tremor filtration, which madam also showed you. Then there is the motion demultiplication and paradoxical inversion in laparoscopy. So if you move a little, you feel it's moved a lot, right? So all that is not the problem that we see in robotics, because the motion is transmitted very precisely. So if you have to move a millimeter, you can move a millimeter in robotics. That's how it is. And the vision is excellent. So they all have endo-wristed instruments. So basically it is like your own wrist. How you're doing open surgery, you do all these movements, right? You can have the exact same movements in a robotic instrument. So that is the enhanced motion arcs in the robotic instruments. So in lab, we have the 2D and 3D vision, but in robotics, we have a highly magnified vision with a 10x magnification. So lab needs camera, needs white balancing. Here it's inbuilt. And lab is mentally and physically taxing for the surgeon. You have to stand, you have to hold instruments, you have a wrist, shoulder pain, neck pain, all of those neuropathies start eventually, but here it is a relaxed, comfortable position that you sit at. And in lab, you'll have the monitor position may not be adjustable, but it's like most of the times there is one monitor that's available in the OT. So if at all there is a vaginal assistant, he'll have to look like this and try to assist us. Yeah. So, but in our robotic OTs, most of the robotic OTs, you'll have like we have around 1, 2, 3, 4, 5 cameras. So wherever you look, you see a monitor. So that's how it is. So anybody can look at any time and can tell, okay, this is what is happening. So that's something which we have. And so in laparoscopy, you would have known that, you would have seen that there is manual rotation of the camera, right? You keep changing the light cable. Sometimes if the light cable is loose, it will fall off. If at all you're assisting both camera and the assistant port, if you're handling, then you'll want another person to keep changing the light cable to adjust the rotation. So, but in robotics, we have both 0 degree and 30 degree cameras available. The 30 degree can be done up or down with a click of a button. So these are the advantages with robotics over laparoscopy. But the disadvantages, I wouldn't say disadvantages, maybe the challenges that we have are the cost, availability, lack of haptic feedback, that is the touch sensation, which the DV5 has actually taken over, and now we have a robot which is touch sensitive also. So of course deep Trendelenburg position is needed. Anywhere between 25 to 40 degree Trendelenburg is what is needed for a robotic surgery. And of course specialized surgical training, but it's much easier to learn than laparoscopy. So why robotics in oncosurgery? It allows the adherence to oncological principles and has comparable outcomes, impeccable vision and precision, brilliant dexterity, so you can do complex surgeries, better access in the narrow pelvis, beautifully done in previously operated abdomen with a lot of adhesions, and in recurrent cases of the disease with very less injury to all these organs because your vision is excellent and very minimal blood loss. So most of our patients would have a blood loss of less than, I would say, 10 ml even after the entire surgery. So, and of course excellent repairs are possible even if an injury occurs. I just wanted to show you this. There was a patient with lot of adhesions, and how we could easily, there's something called chromo differentiation that is there. So with the color differentiation, you'll be able to get to know which organ is where. So with that, you will be able to make out the planes, and hence the dissections are easier. Of course, the smaller incisions, less pain, excellent healing, small scars, minimal adhesions, early recovery, reduced complications, and reduced hospital stay, faster recovery, physically and mentally relaxed surgeon. So this, as an open surgeon, I used to love doing, but when I visited the patient next day for rounds. This is how she used to look. But this is the vision that we have now. This is how we operate now. Doesn't mean that we're not doing open. So this is how we see her now. So most of the time our patients greet us in the corridor when we go for rounds in the morning. So we follow something called the ERAS protocol, the early recovery after surgery. So we see that they ambulate the same day. We see that most of the time catheter is removed the same night. They're allowed orally within 4 hours. And so by the time all that physiology is maintained, whatever was pre-op is also maintained post-op. So that's how the recovery is excellent. Thank you.
Thank you, Dr. Punya. Any questions, please?
Port placement for para-aortic. Do you like sort of rotate the boom and do it, or go with the higher placement of the ports?
So we take the camera port just a centimeter or 1.5 centimeter above the umbilicus, and we triangulate. We don't, if we are doing para-aortic, we don't put the ports in the same line because we need the boom to rotate.
Yeah, so you rotate the boom and
we'll go 3 centimeter lower to the umbilicus.
Okay.
So the rest of the ports will be,
remain.
so there's a triangulation. So anyway the camera 30-degree up we can do, and these two will help us with the surgery.
Okay, thank you.
Anyone else with questions? Okay, I hope everyone is awake. If not, I have a few questions to ask. I am easy to lift but hard to throw. What am I? Wake up, people. I'm easy to lift but hard to throw. Feather. I am an odd number. Take away a letter and I become even. What number am I? Yes. What thrives when you feed it but dies when you water it? What thrives when you feed it and dies when you water it? Fire. Someone said fire. That's the right answer. Okay. The next talk, I would like to invite Dr. Prakriti.
Can you switch this off? Slideshow full screen. So as part of our gynec workshop, I would like to conclude by telling about a few cases which is a little unusual than we see in our daily practice. So I think in my first talk, if I've made it a little heavy and if I've made robot seem a little too complicated, now I would like to make a comeback by saying that if you feel the robot is complicated and it is something heavy, it is here to make our life easy and especially the patient's life easy in certain cases which we're going to discuss now. It's not changing. So the first case is of a 32-year-old lady who was a P2L2, who was referred to us by a physician with dull aching lower abdominal pain, which was more on the left rather than the right, from past 1 month, with few exacerbations in between. Because she was not, she just thought it was just a routine pain, it will come and go, and only she had a few exacerbations. She hadn't shown it prior. So when she, other symptoms which was associated was, there was just a little bloating, but no other predominant gastrointestinal or a genitourinary symptom. There was no fever or any specific aggravating or relieving factors, even though she had exacerbations in between. The menstrual history was normal, family past history was not contributory. Only thing was a recently detected uncontrolled diabetes mellitus at that age. So on examination, there was tenderness present on the left side of the abdomen, but it was on very deep palpation. So on gynec examination, there was minimal tenderness in the left fornix, and a boggy mass was felt in the left adnexa, which was not very well defined. So the imaging and all was suggestive of something there in the left adnexa, which was thick-walled, mimicking a complex solid cystic lesion, which is just sitting in the left adnexa without knowing the origin where it was coming. So we decided to go in, and we got a few investigations done. Her blood investigation showed that she had a hemoglobin of 8. Her counts were 14,000, which was in the increasing trend compared to the prior reports, but she had no fever. So the CECT report, CECT was done first, because usually that's the thing that they do after a routine ultrasound. That showed a 7.5 into 6.5 centimeter complex left adnexal mass, which was done 5 days prior to coming to us. 2 days later, they've done an MRI in which the size had already increased to 11 centimeter mass with the same characteristics on the left side. So now, with the, and her HbA1c was 12%. So with all these in mind, our differentials before we went in and operated was a left adnexal mass, possibly with a malignant potential. That would be always the first thing for us to rule out. Could be of ovarian or a tubal origin given the adnexal location. Could be a TO abscess or a tuberculosis or a endometrioma. With these things in mind, we had counseled the patient. We will go minimally invasive initially. If anything and the need may be, we may have to even open up. And there were possibilities, because in the images and all, we were able to see significant adhesions to the mass. So we had also counseled the patient there could be bowel injury and a possible bladder injury. If anything would require us to save your life, we may also have to end up doing a hysterectomy and a BSO, and with staging SOS. So we had also kept our frozen section team ready. After seeing the intra-op picture, we would decide on that. So here is what, because of the odd recording system that we had for the past few days, we were not able to get the full recording, but here I would like to show a bits of what we went in and saw. So this was the initial picture when we went in. Lot of extensive adhesions, few were flimsy, few were dense, especially as we went closer to the mass, the adhesions became more and more dense. So this was the mass stuck to the anterior abdominal wall with no proper delineation of the mass and the abdominal wall. So as and when we started separating, we always had this thing that we were more closer to the abdominal wall rather than to the mass. After the dissections were done, we were able to delineate the left adnexal mass, albeit we don't know still where it is coming from. We thought we'll go to the lower extent. So left side, we were able to go as much as to the left uterosacral, but still of no use. At one point when dissecting, this came out. So once we went in only, it was very clear that it is something more inflammatory and infective rather than any other pathology. So as and when we dissected, it went on oozing in that left region. So once this happened, so our suspicion went into two directions. Could it be a TO abscess or something in the intestine? But she had no GI symptoms. The location was very much closer to the sigmoid colon. So we also had our gastrointestinal surgeon come in and have a look at it. So as and when we dissected, we went closer and closer to the lower margin because we were rest assured that this is a TO abscess. An abscess which is there, probably not a TO abscess. And as and when we went closer to the uterus, you will see, so it was adhered, and when we were trying to separate out the adhesion, that is when we saw and clearly visualized the ovarian ligament. So then it was a reassurance for us that this is a TO abscess which has grown extensively up to the size of 12 centimeters, sitting in the left iliac fossa and going beyond the false pelvis. So when we dissected it out, we dissected it completely from the lateral pelvic wall. The general surgeon ensured us that the colon and everything has been safe. There has been no injury of any sort. So we took it out from all the directions, and the cyst cavity, we can't leave it inside. So we had already drained the abscess. So we then came out by taking out the complete cyst cavity, because she was just 32-year-old and she has had a ectopic pregnancy and her right tube and ovary were absent. So we couldn't risk, or wouldn't want to put the risk of going into very early menopause by taking out even the left ovary. So we took out all the diseased cortex and the diseased portion of the left ovary, and were able to leave back around 50% of the cortex in the left ovary, so that her ovarian function is maintained. So you could see the amount of adhesions that is there. And the robot, because we are able to go so close, even in open surgery, the distance between the hand and the instrument tip is around 10 centimeter according to the length of the instrument. Here, the instrument moves very close to the tissue, so we are very easily able to do precise dissection. So this is where you see the right one was absent. Here we have taken out the abscess cavity, and the left ovary has been left behind. That was where the abscess was completely. So after this, we gave a thorough wash, put in a drain, and everything was done minimally invasive with no incisions apart from the 8 mm incisions. And there was one assistant port only apart from the 3 robotic ports. So one of our pathology decided to go a little off-road. So this is a case of that. So now again, she is a 32-year-old unmarried girl, non-sexually active, who came to us with severe left-sided lower abdominal pain just since 1 week. She had her regular menses with no particular dysmenorrhea bothering her life all through her life. Only thing was a severe PMS history, little exhaustion, and weight gain also is what she had compared. So all this we would also attribute to PCOD. So on evaluation, this was just on evaluation, per abdominally, we were able to feel a mass, abdominopelvic mass in her left lumbar and iliac region. But particularly because it's so big and that age, we still wanted to go in and get an imaging diagnosis as well. So ultrasound revealed a 13 centimeter fundal subserosal fibroid with a 15 centimeter, mind you, this is 2 separate lesions, 15 centimeter right adnexal complex cyst, again adnexa. So we don't know again the origin. So the MRI confirmed the same, with the sizes were same with here and there a millimeter difference, with the suspicion of right-sided dermoid cyst, because it had a solid cystic component and a fat content, and it was a very well-defined mass extending up to the right iliac fossa. So they gave us a diagnosis of a dermoid cyst. And all the tumor markers that we got done for her was normal. So we decided to go in. We went in with a suspicion, okay, there's one subserosal fibroid which will come out easily. Only thing will be to extract it out. And our next headache would be the dermoid cyst, because it's so huge. Without rupturing it and without creating a mess inside the belly, how do we take it out? These were our only 2 concerns. So we had our plan of action ready with 2 bags, probably take 1 mass out and again go in for the second mass. So this was our plan of action when we went in. But once we put in the camera in, that is when the story completely changed. So because we knew the subserosal fibroid would be easy to dissect out, so we thought we'll first invest our energy into the mass that we see. So, sorry, 1 minute. Yeah. So as you can see here, so this was the subserosal. So this you can see here that there is a mass here which looks retroperitoneal. First thing we saw was the ureter. So it was lateral to the ureter, somewhere beyond the IP ligament. So we went in with a very meticulous dissection and opening of the retroperitoneum parallel to the infundibulopelvic ligament. And we wanted to see the extent. It was going up till along the psoas, which was going up till the right lumbar and up till the lower border, just below the lower border of the kidney probably. Then in this location, because we had already seen one case of psoas tendon mass, we also had a differential in mind. This could be that also, because it is in the same position. So as and when we dissected and we started releasing it from all its attachment, though flimsy, it was still there in that position, and it was purely retroperitoneal, and peritoneum was easily moving. So we went in, after the dissection was done at the upper end, we started dissecting at the lower end to see what it is and till where is it going. only when we went deeper and deeper, we were able to see the solid portions of it, which looked more or less like a fibroid consistency, which was firm, not very invading, or which did not have any major attachments. So once we started, but the upper portion completely had a cystic consistency. So now we are going in the right lateral wall of the uterus, separating it out from there. This posteriorly, what you can see is the posterior leaf of broad ligament. So as you dissect, you can see how the scissor is so precise, and even a small bleeder was caught without injuring, without much of a lateral spread. So now we are going closer and closer to the uterine. So as you see these solid portions which is popping up now. So this gave us an idea. Could this also be a broad ligament fibroid? This is when we went into the uterus and the solid portions attached to it came out. Could it be a solid broad ligament fibroid with a degenerative change in the upper end? So it was also into the obturator fossa, going laterally right side. You can see the external iliac vessels here. So this amount of meticulous dissection is very, very difficult to achieve in laparoscopy without proper traction, without giving a nick on the cyst. With being so gentle, it's not possible. So here is where the attachment started, because it was more densely attached and vascular. So this is where the fibroid arise from. It was completely a broad ligament fibroid solely, with no uterine attachment, and even the ureter was free. But it had gone up till, because when it started in the broad ligament, it has started as a solid region. As and when it grew and reached the lumbar region, it has undergone a severe degeneration, which was cystic and fatty both. Because it had both the components, they gave in the differential of a dermoid cyst. But only when we went inside, the story completely changed. So here we are separating it out completely. This was the last bit of the dissection. So as you see, as it goes to the base and the origin, the vascularity has increased. Rest of the portion was comparatively better. So with this, we were able to achieve a complete clearance. You will now see the cavity, amount of place that it was occupying. And this was a primary reason for her pain, not the subserosal fibroid. It was occupying such a huge space. So it had started almost from there. Genitofemoral nerve, you can see, external iliac vessels, you can see. This is the rent in the broad ligament, and this is the right uterine vessels that you can see. So this was the extent of that fibroid. And this is the subserosal fibroid, which was occupying the pedunculated fibroid, which was occupying the entire fundus. This was normally routinely removed with vasopressin injection and, cut on the fundus, and then we could extract it out completely. So this is another unusual case which we gynecologists will probably never come across. A 77-year-old lady, obese, presented to us with a right leg pain and a limp. So this is not the usual presentation. They usually come to us. They usually go to the orthopedician, neurologist. So the same the patient also did. She was evaluated and an MRI spine was done, which picked up that there is again something in the right adnexa. Okay. On examination also, we were able to see a 10 into 10 centimeter solid cystic right adnexal mass, which was felt impacted in the pelvis, extending to the lateral pelvic wall along with the small fundal fibroid. Again here, all the tumor markers were normal. Very similar picture to what was there on the earlier lady. So when we went inside, we again went in with the suspicion of something could be arising from the ovary or the tube in the right adnexa. Then when we went inside, we saw that the uterus, though bulky, was free from the mass. The ovaries were free, the tubes were free. This was sitting in the posterior leaf of broad ligament, around of the same size, 10 into 10 centimeter. So this is when we started to open up the, please just give me a second. Yeah. So that was a fibroid which was marked. So that was not of our primary concern. So we started opening the peritoneum over it. So because now here as you can see, we went deeper and deeper, moving it away from the vessels. So we even opened the retroperitoneum anterior to the infundibulopelvic ligament, and then we started to approach the mass. First we started posteriorly, then we understood that it is going more anterior and lateral, so we changed our approach and came to the infundibulopelvic. So here is where you can see the mass, which was deep down in the right adnexa, somewhere close to mid-body and the lower body of the uterus. So on feeling, because the robot doesn't have a tactile sensation, and by experience we will be able to feel at least the bone and the tissue caliber. Initially it does take time, so we depend, for certain unusual tissues, we depend on the assistant who is using a laparoscopic instrument to feel what it is. So when we felt it, it was not it was a firm mass, not a very cystic mass. So a serous colored fluid, as you can see, what has come in now. So again we went and digged deeper into to separate it out from its attachment. So here this is the primary area where all the major vessels come in, the obturator, internal iliacs, and the obturator nerve, hypogastric plexus, everything comes in this area. So we found the cyst wall, so we thought we'll start extracting the cyst wall. So this was very unusual for any, because that place is not of any other gynecological mass that we can expect from. So once we reached here, because we were able to see the nerve and everything, the only structures present there would be either a broad ligament soft tissue or the levator ani musculature from where the tendons or any mass coming from that, or the nerve related tumor. So one of them that we suspected was a schwannoma when it came, when we thought that the area is that. But most commonly schwannomas are not seen in that area. It is most common in the internal auditory meatus and other peripheral nerves, even though in general only it is rare, mostly associated with NF. So here we were still skeptical, probably not, it is not. So we still went ahead and we dissected out and tried to take the cyst wall out. Though it came in piecemeal. Sorry for that. Yeah. Yeah. So as in when we went deeper and deeper, it was extending almost till the obturator fossa. So till now our only thing was it is something in the obturator fossa mass in the right lateral or adnexal region, which will need evaluation. So once we started to separate out the cyst wall separately, it went in deeper and we thought we'll have to go with meticulous dissection. So even though the place is so strategic, you can see we have not touched the nerves, nor the ureters, nor the vessels. Even the bleeding to that area is quite okay. And because we needed a visualization, we were irrigating also in between. So it was completely separated out. This was stuck to the right obturator fossa. So that was the lateral extent that we saw. Lower, it was touching and stuck to the levator ani muscle, so it was so deep. And then upper, it had come almost up till the mid-body. So you can see that initially we were medial to the vessels. Now we wanted to see the lateral extent, if at all there is any. So because we did not want to leave any portion of the mass. So we went lateral to the vessels and saw if there was any portion of it. So luckily we did see a portion, but it was easily accessible from the medial side itself. So then we are going in and now taking out the mass. So let me show you a little later picture also. So here, one thing that I want you to notice, how many times the suction is coming in. Because if the dissection has to be neat, especially in such a deep structure, then we have to be, the assistant has to be very meticulous in the way they do the suction and makes the field clear for the surgeon to see the right planes. Else we end up cutting a wrong plane, going in the wrong plane and injuring vessels. So this is where the assistant helps a lot. So it's important even the assistant is well versed and well trained in robotics as well as laparoscopy. So you can see more of fat tissue coming. So fat, always myelin, nerve sheath tumors is one thing which goes towards it because it has no other component. So the entire mass was open, it was taken out in piecemeal itself. Then we went in for the fibroid. Let me forward this, I'll show you the end picture. So we had kept a gauze piece to see if there were any unusual, unexpected bleeds. So let me pause this. Yeah. So you can see the mass was somewhere here. This is the internal iliac vessels. Sorry for that. This was the internal iliac vessels. It was just sitting between the internal iliac and the external iliac vessel, with the base made with the levator ani and the right obturator fossa, and superiorly it was extending into the broad ligament coming up till the mid body. So to give a clear anatomy, I have put in pictures here. Sorry, my cursor is not moving. Okay, you can see that the pararectal space, all the spaces that we usually open in the rectoperitoneum were opened, and it is very important to tailor our approach, because we went in thinking something, it may change in between. So we must be ready with whatever area of dissection and how to dissect is what we need to be very well versed prior as well. So robot helps us to do that. So sometimes if we may think it is a simple ovarian cyst mass, and if it is not, and if it is something deeper, and if we are not well versed enough with laparoscopic dissection, and such deep dissections are, even for a experienced laparoscopic surgeon, might be difficult. Please correct me if I'm wrong. Robot definitely helps for us to go deeper and give a complete clearance of that area. So it was a schwannoma which came in with the histopathology report. Then we had to refer her back to the neurologist as well. These schwannomas are benign tumors. Nobody comes to us with that. No gynecologist would have encountered it very frequently. And in that region, it is even more rare. So they are benign tumors arising from Schwann cells of peripheral nerves. The common sites actually are the head, neck, upper limbs. Pelvic location is very rare. Clinical features vary based on the tumor size and the nerve which is involved. Very oftenly we are not able to make out which nerve is the one which was involved, because it comes as a sheath, and the sheath can be arising from any peripheral nerve, even a fiber. Malignant transformation is very rare, which is less than 1%. Surgical excision is the treatment of choice. Although well encapsulated, their position may make resection a little difficult, because we have to take it out without injuring the major nerve. It might be difficult, but the robot helps us to do that. The nerve of origin is frequently not identifiable. Recurrence is uncommon if there is a complete excision. So this was done a year ago. So the patient currently is under the follow-up of both us and neurologist more frequently. Now her limping is gone. She doesn't have any pain in the hip or in the leg. And she's been screened every 6 months now. Then there has been no issues with her at all. She has completely regained her confidence, because she was thinking it could be something. In that age we think of paralysis and what all could have happened, but it was not that, and patient was relieved. So again, in a very unusual case where we have bridged the gap, it is a 34-year-old woman. Mind you, it's a 34-year-old woman presented with stress urinary incontinence. The symptoms significantly affected her daily activities and quality of life. Why do I stress upon this? Because many women may not come up until it becomes a quality of life issue majorly. She had previously undergone a male to female gender reaffirming surgery. So it was a male who had come to us after a gender reaffirming surgery done elsewhere. It was 6 months post that surgery who she had come. So she wanted to be addressed as a she. She was very particular. And all the paperwork, everything, she had made sure that it is ensuring that she is addressed as a she. So she went in and she had already gotten a pinectomy done, bilateral orchidectomy, sigmoid vaginoplasty to create a vagina, a clitoroplasty, labiaplasty, and a urethral reconstruction as well. All this was already done, and the outcomes were also good. Even the vagina had good length. But 2 months post-surgery, which was their immediate post-surgery as well, but they did give it time because it was a urethral reconstruction and a vaginoplasty. But there was persistent stress urinary incontinence even several months later, even after all her tissues healed. So initially conservative management was tried, pelvic floor, muscle training, lifestyle modification, even laser vaginoplasty was done to tackle the stress urinary incontinence. But we need to understand one thing. It is a male urethra which is there. It is not the female urethra which has a vaginal support. So now what do we do? Vaginal approach was deferred due to the new vagina. First of all, it's a repeatedly operated area, and in a new vagina, we go inside and do a TVT, doesn't make any sense. So now what did we do? We went in with a novel approach, because we knew that all the male organs were away and there is no uterus and ovaries which will be bothering us. We thought we will anchor the urethra to our pectineal ligament, how we usually do in a Bush colpo suspension. But what do we anchor to? The vagina, paravagina is not something naturally that God has given her. So the tissue that we found was her prostate. So this was the picture. For that much amount of extensive surgery, the adhesion that she has had was very minimal, I would say. So what we are trying to do here is, first we'll take down the adhesion. So for Bursch-Colpo suspension, for any other reconstructive surgery, we go intraperitoneally and then approach retro. Now we are directly going into the pre-pubic space. That is what the urologist famously called as dropping the bladder. So we need to drop the bladder now. So let's finish off the dissection here. Yeah. Ah, yeah. So you can see that was a bladder where the Foley's bulb was put. So I'll just so we have dropped the bladder, and now we are going down towards the anterior part of the urethra, and that is the pubic symphysis where it hosts the urethra. So left side, if you see, initially when ma'am was showing the videos, it was the pectineal ligament on the lateral end. So when we do a Bursch-Colpo suspension, or in here we are approaching the pectineal ligament from the medial end, that is just lateral to the midline. So we need to drop the bladder and open the pectineal ligament on either sides. So you'll see that on the right side, you can already see that the pectineal ligament is open. Yeah, this is the left side. So we have opened both the sides, and now we have joined it in midline. In midline, we have not left any tissue. So from left to right, you can see one arch of the pubic arch and the pectineal ligament along with that. So now this was the dilemma. What do we anchor it to? This is where we were thinking. We have found the pectineal ligament, but what do we anchor it to? So then we went ahead and saw that as we dissected, obviously we have a very robust team of urologists also who are always ready to help us. So we went ahead and dissected the prostate. So here you can see it was the finger, in vaginal assistant finger in the neo-vagina, to see where the extent, till what extent do we need to anchor it to. So that is when we saw the prostatic bulge. The prostate wasn't removed. So we are now going ahead and finding the prostate, because the prostate is a highly vascular organ. It has a deep venous plexus around it. Usually even in a radical prostate, they use certain maneuvers so that if they go very near to that and a bleed happens, so they're always very well prepared with an extra pressure in the pneumoperitoneum and having vascular clips ready at hand. So, and also one more reason for her stress urinary incontinence and failure of the conservative management was, in the male urethra, the prostatic urethra is a wide urethra, which is equivalent to our bladder neck where we put the tape or suspend. So that is why, because she did not have any other part of urethra and a wider urethra only was left behind while urethral reconstruction, obviously she ended up in a SUI. So what we went ahead, we separated the prostate clearly. We have taken anchoring stitches to the pectineal ligament to the prostate itself. So it is like a pulley, figure of 8 how we would take, it is like that. So this will be done on either side. You can see now once the tension comes, it is being pulled up. But we did not do the tension right away, because we had to ensure both the sides are being pulled equally. It can't be lopsided. So we took the stitches on either side of the pectineal ligament and the prostate. Usually in Bursch, we take it to the paravagina. We have a vaginal finger. We know where the urethra, our 4 centimeter urethra is. We elevate the paravaginal tissue and we anchor it to the endopelvic fascia of the paravagina. Here, because we did not have that liberty, we have anchored it to the prostate. This was a very novel procedure even for us, because there was no other way. We definitely offered her this, and in the meanwhile, I'll let you know the outcome as well. So we are now slowly increasing the tension, and this was ethibond sutures which was used. Hence, we will, even Prolene would have needed the stay from the Maryland. So this is one side. Both the side we have taken the medial side, but this may not be enough. So we again went in with the Prolene and took one more bite, a little lateral to both these stitches, so that equally the prostate and the fascia is elevated and supports the urethra. So this is how it was done, and this is how the end picture was. So surgically, this was the end picture, because we are not putting in any mesh or anything, and the bladder, after the pneumoperitoneum goes, it reperitonizes. So we were done with the surgery then. Post-surgery, initially she did have the SUI, but as the days passed by, at around 3 to 4 weeks time, post-surgery, her SUI was 80% resolved. She came to us telling that I am absolutely leak free now. Only occasionally here and there I do have, but now I'm very happy with the outcomes that has come. Now I feel that my gender affirming surgery has been complete. Now I feel I have achieved the feminine complete achievement. So now it's been more than 8 months that she has been following up with us once in 3 months. It is 100% leak free. So she doesn't have any SUI. So this was something which was very unusual. Even we also had a doubt whether this will work, whether this will hold, but it has. So main take home points is the urethra needs support. In this case, it was a male urethra, which was unusually wider, obviously. So the urethra needs support. Whenever there is any sort of urethral reconstruction, it will lose that support with the paravaginal tissue. So we have to bring back that paravaginal strength, which will bring back the urethral integrity as well. Because she was already on hormones, so we couldn't give any excess of hormones in Evelon or do. Now the maintenance can be given with pelvic floor physiotherapy, and if need, maybe even a laser procedure can be considered. But as of now, she doesn't need any. So a very last interesting case, a small part of it I'll try to tell. There were 2 cases of ours with different etiology, but inside it was the same surgery and the same type. It was a 20-year-old phenotypic female presented with the desire for vaginal reconstruction and an absence of a vaginal canal. She was a male genotype 46XY, which was detected in her childhood and infantile stage itself. And she has had she had already undergone a bilateral orchidectomy at the age of 5. She was a case of complete androgen insensitivity syndrome. The second case was a 24-year-old phenotypic female who presented with primary amenorrhea and an absent vaginal canal. Even she was evaluated elsewhere, and she already knew that she did not have a vagina. So evaluation was consistent with congenital uterovaginal agenesis. She did have an ovary. It was a case of Mayer-Rokitansky-Custer-Hauser spectrum, and within a case of 46XY. So this required both of them required a vagina itself. They obviously knew what they had. They obviously knew they couldn't have biological children. They obviously knew that nothing extra in terms of menses can be done. But for sexual function, they needed a vagina. So this was discussed with them. A multidisciplinary approach was taken, and they both were planned for ileal neovagina. So here, this was the intra-op picture. See, this is the bladder, and this is the rectum. And this you can see a rudimentary uterosacral attachments which is there, which could have been the place of uterus in between. So we went in between, and at the vaginal end we only have a dimple, hardly 1 centimeter, which we can push in and show. So we almost had to go till the pelvic floor. Our intention is to almost go till the pelvic floor and then find out. So there are many ways of vaginoplasty. Ileal neovagina, we have found that has given the best results in terms of size, dilatation, and sexual function as well, in these 2 cases at least. So now we are going down and approaching that place where, if you can see, a small area is moving. So that was the vaginal dimple which was being elevated. So just like in sacrocolpopexy, how do we dissect the anterior and posterior? We have done the dissection and tried to open. We give a nick on the vaginal dimple, which was a rudimentary vagina which is there, and then we try to open it out. After that, canal is created. Now we need to bring the ileum. So what do? We identify a segment of ileum and put in a suture. Why the ileum, and why didn't we prefer a sigmoid? Because I'll tell you the major reasons here. Ileum is a long segment, so even if we resect and anastomose, it's easy for the intestinal function to come back earlier. So we took we identified a place, and then we took 4 centimeter on either side. So it was around 8 to 9 centimeter ileal segment which was considered. Then we are going ahead with the resection. So here one thing to note is we can't take out ileum, just the lumen, and put it back. It needs vascularity. So we have to take it down with the mesentery. So we cut in only the lumen and leave the mesentery behind. So this is repeated on both the sides. So if you imagine now, one loop has come like this, which has come, and the rest of the intestine is left behind. So because the mesentery is vascular, we are going in with the vessel sealer instead of just the scissor. So this is a laparoscopic vessel sealer which has come in. So we keep the mesentery intact and cut it out. So now we need to reanastomose. So while reanastomosing also, we have to make sure that it is not a twisted segment and that there's no volvulus, and a proper segment only is reanastomosed. Here we are using a laparoscopic stapler and doing a side-by-side anastomosis. So you can see how fastly the anastomosis also was done. So the intestinal integrity was ensured, and then we now fashion the vagina. So this is a doubly, both the sides the lumen is open now. So we can't put in one end and suture the other end, because it will not give us a proper dilatation. It won't allow the dilatation to happen. And vagina needs at least 2 centimeter, 2 finger dilatation to happen. So what we are doing, we are cutting the anti-mesenteric border and making it into a rectangular sheet of tissue. So after we again check whether the ileum is coming till there without tension. It has to come in without tension. If it is with tension, it will tear away. Now you can see we are using the barbed sutures. On one side of the rectangle, we are folding on itself. So it is only one side we are taking stitches. We identify the midline of one side and then taking stitches on either side. So this will make that side completely collapse and make it into like a parachute, the head of a parachute, for which we are going to anchor the this will become the new vagina. So now see, we folded it back and it became like a curve of the parachute, which we can see, like a hot air balloon, which is there. So now we take that ileum back, ileum to the vaginal end, and then we suture it. Even when suturing, one point what we need to remember here is the sutures which we take has to be loose and not barb sutures. Initially only if we tighten off, the same new ileal segment which we have taken will block our further bites. We can't see it. So what we do, we take bite on the vaginal end, we take a bite on the ileal end, again take a bite, again take a bite, take a running suture which is loose. At the end, when we are about to tie, we tighten it all together so that it goes and sits into the vaginal dimple which was opened. So then that tightening is done only at the end. So this was how it was after tightening. So this patient, both of them have been in follow-up with us. So it's been 2 years for one patient and 1.5 years for the other patient. They have achieved a 9 centimeter vaginal length. After this, we do keep a mold to keep the vaginal bulb inside and keep the vagina intact without collapsing. And then she'll need a gradual vaginal dilatation. They both are still on vaginal dilatation because they need to maintain the width and the breadth. But the final achieved length after 2 years is a 9 centimeter vagina with a 2 centimeter width. Obviously at the end where the ileal segment was there, the width is a little broader. At the entrance at least, it is easily 2 finger can pass. So why did we choose the ileum? It is a well vascularized, long, non-keratinized segment which is naturally lubricated. We need not think about the lubrication. And it gives a favorable long-term patency. Compared with the skin graft method, it avoids donor site morbidity and may reduce the tendency towards contraction because skin has that healing property and it contracts and can lead to stenosis in the long run. So post-op, obviously, gradual vaginal dilatation is advised. So recently we got the opportunity to publish these 2 cases also. It is now in the journal for Curious, which is a PubMed index journal. So you could all definitely have a go through with this. Thank you for your patient hearing.
Any questions?
Post-op
Yes.
secretions.
Yes, ma'am. So post-op, immediate post-op, they did not have much of a secretion. It was just blood and all of it. But yes, after 3 to 4 weeks, they did start getting the secretion. Because we have taken it with the vascularity of the ileum, initially for it to be taken up as a vagina, it will take time. But once it is completely adhered to the vaginal canal and the body gets adjusted to what the requirements are. So it will not secrete so much as it used to secrete inside the intestine. So now the discharge has completely come to a bare minimum. It is not that much where it used to bother them. So I would say around, I think, 2.5, 3 months, if I'm not wrong, it was bothersome. The discharge used to come so much that they had to use panty liners, and they did have that complaint. But now it has completely reduced and come to a bare minimum. So that is one thing.
Anywhere else it was done, and how was the outcome, ma'am? That same thing. Outside India? Any studies?
There are a few studies, not lot, because many of them use many other methods, McIndoe's, Davidoff, because some use a skin graft only. Directly they open and then just keep a graft, and amniotic graft is used. Sigmoid, as a previous case, sigmoid vaginoplasties are used. So the case papers now are favoring more towards ileal vagina. So there are, I think, reported close to 50 or 60 both lap, open, and robotics. These are the only 2 which I could find what we have done. Others may have done it, but I did not come across it, but I did come across laparoscopic surgery and robotic repairs in like sigmoid vaginoplasty and all they have done. But now the superiority of ileal neovagina is coming up because of its long-term patency. And because in skin, again, it may shrink, it may come down if any time the vaginal dilatation is not ensured. In the ileum, once it is taken up, the ileum is a more favorable segment and more similar to the vaginal musculature. So it doesn't shrink so easily. Even if it does, again, from gradual dilatation, we can open it out. But if the skin, if it shrinks, again, we have to make a nick only. That's how contractions and facial releases are done. So instead of doing that, ileal neovagina has given a superior result. Sigmoid also can be given, but some people may end up with colostomy and all of those things. But ileum doesn't need any of those things because it's a long segment. We can pull out a longer segment to come and sit there. And a good vascularity from the mesentery helps, adds an added. No, ma'am. See, it is in general what we expect in a minimally invasive, only that. So if a preoperative antibiotic and proper sterility is ensured, there is no particular increase in postoperative infection and all of it, even though. No, ma'am. We at least haven't encountered in these two cases, did not have any infection. No. Yes, this one patient did have diarrhea later, like due to food poisoning and all of it. I mean, she came to us later only, but we made it a point to ask if there was anything unusual happening in your vagina as well, because that's the beauty of the body. The body adjusts to what the function is. So, I mean, that's why many people who have had prolonged, orthopedic bed rest and all, muscle undergoes atrophy. Muscle will not do its work because it feels that obviously I have no work now and it will not function. So if we keep exercising the muscle becomes hypertrophy. So the body adjusts according to the function. So whenever there was an infection and after a certain period of time, it stopped behaving majorly like an intestine and started only with minimal secretions. That's it.
Any chances of fistula formation?
Oh, sorry.
Yeah. Any fistula formation or?
Ma'am, only thing
how
where
do you educate them about what to look for in case of such?
Acha. See, only thing we don't usually explain for a fistula in this case, because unless there are dense adhesions and we end up injuring something inadvertently and we don't recognize it, there is no chance. Second place where that could happen is where there is a resection reanastomosis. If the anastomotic site has a leak, or if the sealing is not proper, side to side, or the top anastomosis is not proper, yes, that time there could be a fistula, leak, peritonitis, and intracutaneous or entero, all that can happen. But if the seal is ensured, this usually doesn't happen, ma'am. And that seal initially, because we was taking stitches for the anastomosis, probably was a little higher. But in the stapler anastomosis, it completely watertight. So this NPO also, we were able to break the NPO patient's NPO. We were a little skeptical, but the gastric surgeons were like, no, you still can go ahead. By the time food reaches the ileum, it will still take time. You can break it as per your ERAS protocol. But we were more conservative, and we started only after 12 to 16 hours only. But still, there was no rupture or leak or nothing. So they can be early, food also can be given, and they can ambulate early, and both the patients we discharged on POD2, today we operated and day after tomorrow we discharged with the vaginal mold in situ, because initial 72 hours to 3 to 5 days we would like to keep the vaginal mold and then take out and teach them vaginal dilatation. Yes, ma'am. Pre-bowel preparation, actually routinely ERAS even says that bowel preparation is not required if prolonged NPO is ensured. Again, because this was our initial experience, we did not want to take any risk. We had given peg leg bowel preparation, but now we have started not to give that and give a prolonged NPO until there is some contraindication for the prolonged NPO. That's it. So if the NPO is ensured 8 hours for solids and 4 hours for clear liquids, I think no further bowel preparation. If the patient has a lot of constipation, she complains that I don't pass motion properly, in general, we need not give a bowel prep. Normal routine third generation cephalospore. Yeah. Yes, sir.
Can I ask a question?
Definitely, sir.
So my name is Dr. Poonawala. I'm a urologist.
Oh,
and
nice
I'm
to meet you,
interested in the one which was prior to this case which you showed,
yes,
of the prostatopexy.
Yes, sir.
So there are two questions I would be interested in your view. Number one, why did this patient got SUI? That's number one. Because if you do male, want to convert to female, you stay actually below the sphincter. So really, I am surprised that why this patient had SUI. And second thing is, what other options did you think about helping without, apart from what you actually have done? So these two things, if you could throw light.
Sure, sir. So one thing what I can say in the first questions regard is, we don't know the extent of surgery, how the urethral reconstruction was done, because it was not done here, or we hadn't done it. So how much the sphincter was kept and how much the sphincter was injured, or what's the integrity of the sphincter is one thing that we don't know. But what she had was immediately post-op, after catheter removal and all of it, from then she did have a leak, stress urinary leak itself, which was very clearly told. And she was also instructed it will be there in the initial period and gradually it will come down. But when it didn't come down for 6 months, she had a consultation there also where the original surgery was done. But they said this will come up and this will go on, it will get treated. So they had already tried the conservative ones such as pelvic floor physiotherapy and laser vaginoplasty in an attempt to develop tissues which strengthens the urethra, all of that. But none of them had helped. So that is why we went in. And in general, for female SUIs, sir, we usually have the tape approach, the vaginal TOT or a TVT tape, or the abdominal approaches, native tissue, or the suspension procedures that we have. So vaginal was abandoned because it was a neo-vagina, repeatedly operated place, and also because in a natural vaginal tissue, we have the endopelvic fascia buttressing between the urethra and the vagina. Here we don't.
So what was the primary reconstruction earlier? What was the skin? What was used?
The sigmoid was used, sir. For her, a sigmoid vagina, it was a male to female,
yes,
right? So she did not have a vagina, so they had used the sigmoid for the vaginoplasty.
Okay.
She did have a vagina proper,
Right.
2-finger length, a good this thing. There was no problem with the vagina at all. But the vagina itself is unsupported. It is just a canal. So again, putting a TVT tape or a vaginal approach would be not feasible. So that's why we wanted to do something where we do in a female as a bush. So, but we did not have any paravagina. That's why we thought a prostate.
Thanks.
Any other questions? This was a robotic session, so we'll have a small quiz. This is on robotic itself. After that, I'll take over.
So to make things a little interesting, I thought I'll ask a few questions here and there. It's not to test or not to give anyone any more gyan. I'm pretty sure that all of you are doing more surgeries and even complex. This was our area of sharing our knowledge, what we had done. And in case you want to take up, it would be beautiful for you also to take up. So if I have to tell it like a teacher, if you have listened to all of us, you should be able to answer these questions. No, it needs to open in PPT. Open with Keynote. Yeah, it came. Okay. So you have all heard how the robot helps in surgery and all of those things. A few very, little troubleshooting aspects which we usually encounter in a robotic surgery I'd like to touch upon. So this is scenario 1. So please don't go into the case details, why was this not done, why ultrasound wasn't done. This is just technical part in the initial few questions. So a 45-year-old woman with a 14-week fibroid uterus was posted for a robotic hysterectomy. After docking and starting the surgery, the robotic arms repeatedly collide externally, limiting the movement. So this is a very common problem that usually comes up in the initial days. So what would you check and what would you think would be the solution for it? We don't know the problem yet, but what are the things that you could check for? Yes, ma'am. Port placement, yes. What port placement? Yes, so the port, if it is inherently, if it is closed, definitely they're going to clash. So that is one thing that we check. Anything else you would like to check? So even while correct. So when docking, so the robot has multiple joints at the arm. So even the major arm which is docked is away from the port. The other joints could still be closer to one another as we go closer to the column of the robot. So that place also it can clash and it can restrict your instrument's movement. So thing could be we have to ensure that there are 8 to 10 centimeter distance in between the port. If the case need, you can undock, you can take out, undock the completely all the instruments, because with the docking you can't move the patient or you can't move the robot, or else you will be pulling out the ports and injuring the patient's abdomen. So always and always, any movement that has to happen externally should happen after undocking. So you undock, remove the instrument, and you rotate, retarget the boom. That could be done, and reassign the instruments if needed, because sometimes the anatomy may not let us to use the instrument in that particular area. You could always port hop. Yeah, that as ma'am was telling, so there's something called as a port clearance button. It is present only in the 1 and the 4th arm. So the last thing, that button, if you press, the arms sort of rearrange themselves and make place for each other. So usually what we say, at the port level, we say 8 to 10 centimeter distance. At the other joints where I said there could be possible clash, try to keep a 1 fist distance between the arms. Second question, it's a robotic sacrocolpopexy surgery. The assistant reports poor visualization. As I said earlier, for the assistant it is 2D vision, and for the surgeon is the 3D vision. The bowel repeatedly falls into the pelvis despite steep Trendelenburg. So what all could you do to handle the bowel? Even in a lap surgery? Yes, that is one thing. And in lab we use assistant's help or an extra port to take the fan it out. Here also we could do that, or we have a progress for a arm which is specifically meant for the retraction. So it's like a Durga Devi. You are with the camera, you are controlling 2 hands, you have 1 more hand extra which the robot gives you, and you can retract and make it stationary, and you can operate with the other 2 hands, keeping the bowel away from your surgical field. So check if there is any loss of pneumoperitoneum and it has been stable. Inadequate Trendelenburg, again you could check after undocking. If very, very rare in a properly anchored patient, patients let down, incorrect docking, and large bowel not adequately packed or tack the bowel. So halfway through the surgery, the fenestrated bipolar fails to coagulate. The console shows no obvious error. What could be the possibilities? Yes, we are not pressing it. Yes. Correct. Chart tissue we could take out, but connection usually the robot shows. Either it won't work at all. Yeah, it shows on the console. So one thing you could clean and press the correct button, yes. And second thing, very commonly, the instrument usage. All the robotic instruments come with a set of number of uses. So you have to check for the life of the instrument. So if at all it is closer, or if it has been done with it, then the robot will always the instrument will not work. And sometimes intraoperatively you can see the joints, the wire at the joint might have opened up, because of which the arms either don't close or they don't work. So that will be very visible to the surgeon. So that also has to be checked. And always check the cautery pad. So during a sacrocolpopexy, it came off, okay. The surgeon cannot comfortably dissect over the sacral promontory despite full instrument articulation. What are the setup changes that you could see? You have to see if the camera port is too caudal. If it is too close to the umbilicus or below the umbilicus, to invert the camera, you go away and change the orientation may be difficult. So you could put the camera port a little higher, initially only. The robot docked from an incorrect angle. Bowel falling, hold it with the progress or retract. You have to always consider a tilt, as ma'am already has mentioned, but this tilt has to be given either you have to undock the patient or before the surgery itself, before docking in the beginning. So again, a robotic hysterectomy in obese patients, what are the things that you should take care of? You use a bariatric operating table with an appropriate weight capacity. Position a non-slip gel mattress so that the patient doesn't slide, and secure the patient before the steep Trendelenburg itself, and use broad chest straps, avoiding the compression on the thorax. Pad all the pressure points meticulously. Apply sequential compression devices before induction. Yeah, shoulder support, gel support, all of that. So this is again, you can use a bariatric trocar either in the varies and in the port. Place the camera port more cephalad so that you can have a broader area of vision. Because the abdomen is broad, you can place the ports more apart than 8 to 10 centimeter. Ensure the ports traverse the entire abdomen. Any shortage or, if it is too inside or too outside, it won't move adequately. Dock after confirming adequate Trendelenburg with anesthetist permission. Position the patient card to maximize the arm reach without any overextension, because as it overextends, it will start touching the patient's chest. So this is one small video which is showing a port hopping. So this was what we were trying to explain prior as well when we met few people, because all of them are an 8 mm port. If you're not able to visualize from one particular angle, you could change to the other accessory ports as well, because even they are 8 mm. You need not change, you just have to interchange the instruments. So here at one particular point, we were not able to see the addition and see beyond what the addition was. So what we do, we just took out, cleaned the camera. Yeah, it's the... So initially you see the below notifying this thing, this is where the camera is. This is showing that there's the camera here. 1 and 3 are the instruments. That is what. So later when you see, it will come to the 1. So we operated from the extreme here. 2 and 3, that is the center umbilical port and the right side accessory port had the instruments, and we were able to clear out the addition. So when we put it at the accessory port, here the accessory port was on a little lower level. So we were able to see the addition from below upwards sort. So we were able to see that side also what was there, so that we know what we are cutting and we are not cutting inadvertently. Yeah, see here. So now we are seeing from the other side, because this addition in between was coming with this. See, you can see the liver there almost. So the addition, this, you will see the umbilical port also, which is there here, which was restricted. So if it had moved, we were not able to see the addition at all. So from the side when we saw, we were able to see the entire addition, and the additionalisis was done completely. So this is one question which has come out recently in our field. What is this? I mean, we all know what is this, but any particular name? It's, sorry ma'am? No ma'am, OPD device. Yeah, it's a modification of Cuscos. So Cuscos was designed by a man, not thinking about the women. So it is something which was designed by a non-medico, engineers in Germany. It's called a bouquet speculum. It has 5 petals. It is disposable. It is a plastic vaginal design, which is designed to improve over the Cusco, the traditional two-bladed metal speculum. It opens radially. So there's equal pressure on all the walls, and all the walls are retracted away, and our cervical visualization is proper. So sometimes if it is a hefty lady or a lax vagina, only these two are retracted, these two come and fall in between. So this doesn't have, and we need to keep putting pressure, a lot of pressure to keep the walls away if we are not happy with the visualization. Here, because it opens out on all the 5 sides, then it will keep all the walls away, and then it will be, the cervix will be shown very easily. So it's a soft edge, it's a 12 mm insertion tip, that's why it feels more comfortable. And it's a recyclable material, better to use as a disposable as of now. In India, not yet, ma'am. Not yet, but in foreign countries, they're already using it. So there are videos in the Middle East and all of it, they're using it. If we get a hands-on, we will definitely shift to it, because it's more comfortable to the patient and the doctor. Yeah, exactly. All those can be done. Cervical procedures also can be done with ease. So the last question is, I think this everyone would try to, what is this approach what we are doing? Yeah, so you are seeing everything ulta from below. So it was a V-notes with HUSL stitch that we took. So this was the surgery. So this is a gel port that we insert. Similarly, it can be done using a robot also. It is called air docking. Usually when we dock in the skin, we put the ports and then dock. But for V-nodes, we put the ports into the gel port outside the body when it's still not attached. We attach the gel, we dock the robot and then bring the gel port slowly to the vagina. So this is called as air docking. A similar thing what happens in a single incision robotic surgery as well. So here we see everything ulta. This is something that we have started to do now, especially for high uterine uterosacral ligament ligation. We can see the ureters very beautifully, and we are able to do both the sides with no incision and least morbidity to the patient. It can be done as a daycare as well. Morning the patient comes and night the patient goes. Thank you.
Thank you, Dr. Prakriti. I hope you guys enjoyed the morning session. Before we disperse for lunch, a few riddles. Which is the smallest country in the world? Vatican City. What sea creatures have been used in wars? What sea creatures have been used in wars? Yes. Dolphins. Was. Yes. I am light as a feather, yet the strongest person can't hold me for 5 minutes. What am I? No, sir. Breath. I think that's all. You can disperse for lunch now and be ready for the afternoon session. Thank you.
Thank you, everyone, for being here with us throughout, and we hope to see you again at 4,000 and 5,000. Thanks. Yes. And